So globally, approximately 1.5 million people die annually from TBI, and it's a leading cause of disability in young people. These stats are fairly well documented, and it's presumed that a disproportionate fraction of this incidence occurs in low middle income countries, but we have very limited data to support this from a global scale. We've heard anecdotally the percentages. And so because these mortality rates are largely unknown, we decided to do a study to examine what mortality was in low middle income populations stratified by age and TBI severity, and ultimately then estimate the impact and the effect that socioeconomic parameters have on mortality so that we could make some recommendations for influencing national policy from that perspective, not necessarily just directly addressing TBI. Next slide, please. So to get this global estimate, we primarily looked at the literature to identify all possible articles that were looking at TBI reported in low middle income countries. So we started with a systematic review, and we first identified 14,376 articles. And through the systematic review process, we identified 101 articles examining traumatic brain injury in 31 unique countries. And the total patient population we were looking at was 59,197 patients. And the socioeconomic parameters that we identified came from the World Bank and the World Health Organization. Next slide, please. So we initially started off with a univariate and then a regression analysis looking at the stratifications. So looking at specifically age and severity, we were able to differentiate between pediatric and adult TBI and severe versus mild TBI. And we estimated a pooled mortality rate of TBI in low middle income countries to be 16.7%. And we found that severe TBI was significantly greater as expected. And we found this mortality rate to be 26.68%. And we found I've listed the countries here. Certain countries had a higher pooled mortality rate, whereas other countries had a lower pooled mortality rate. And I'll describe what those regions are in the multivariate analysis. But as you can see, this analysis demonstrates that severe TBI, even globally, has a very high mortality rate for patients. Next slide, please. After this analysis, we wanted to look at socioeconomic correlates. So we did a multivariate linear regression looking at a variety of different parameters. But the highlights from this slide demonstrate that median income, percent of population below poverty, school enrollment, geographical location, these were all significantly associated with increases in mortality in TBI. And we found that higher mortality was evident in the Southeast Asian region, and lower mortality was observed in the Western Pacific region. These two findings have been verified in national database analyses in the past. So this was nice to see that we were validating. And to put these findings into perspective, we found that a 1% increase in school enrollment was associated with a decrease in mortality by 0.05%. And it was found to be an independent association through our analysis. And then we also found that each dollar increased in median income in a country is independently associated with a decimal change in mortality rate. So we were able to estimate the direct impact. Perhaps there might be some other confounding parameters that we didn't consider, but we were able to associate the impact of certain parameters to mortality. Next slide, please.
1 minute.
So our critical findings were that low middle income countries have a pooled mortality rate of 16%. And in the US, this mortality rate is 4.6%. And severe and mild TBI have varying mortality rates. And these are statistically different, 27% versus 4.3%. And we were able to show that notable socioeconomic factors impact mortality rate, such as median income, poverty, and schooling. What we need more is studies to estimate the causality of these relationships. For example, how does school enrollment truly impact mortality in TBI? And we also need perhaps more studies to examine social determinants of healthcare in low middle income countries. A lot of the literature is currently in high income countries. And we also suggested that we examine large databases such as the Global Neurotrauma Outcome Study to validate the presented findings, which presents a more comprehensive examination of primary evidence, whereas our evidence has been extracted from published papers. So the next slide is just some thank yous to my mentors and appreciate the opportunity to present today. Thank you.
We have time for one question, if anyone has one. All right, thank you, Anand. Very nice presentation. Moving on to
This is Isabel Germano. Sorry, my screen has to stay on because I have poor internet. Great, strong work, and thank you for your dedication to the field.
Thank you.
Our next presenter is Noah Nichols. He's presenting on factors associated with increased length of stay after endoscopic pituitary tumor resection. His faculty sponsor is Dr. Shrivastava.
Great. Good morning, everyone. So I'm Noah Nichols. I'm one of the PGY1 residents, and I'm going to present factors associated with increased length of stay after endoscopic transfenoidal approach pituitary surgery. Next slide, please. So I'll just introduce this topic by starting with 1 in 10 people will develop a pituitary adenoma in their lifetime. So this is a very common pathology that neurosurgical oncologists and skull-based neurosurgeons will encounter. Recently, the endoscopic endonasal transfenoidal approach has been adopted by most surgeons here in the United States. There are still some providers that use the microscopic TSA approach. However, the endoscope is most commonly used. And as some of you are already aware, I have been working with various members of the neurosurgery team at Sinai, as well as the endocrine team, to basically form a standardized clinical pathway for all of our TSA pituitary patients. And so I wanted to pick projects that would basically correlate directly with that effort. And in this case, I wanted to look at length of stay after TSA pituitary surgery. So just to give you a perspective, the average hospital length of stay after a standard endoscopic TSA pituitary surgery is anywhere from 2.6 to 4 days in more of the recent case series. Most of the increased length of stay is attributable to intraoperative and postoperative CSF leak, postoperative DI, as well as just hypopituitarism. Next slide, please. So for this particular study, we had several aims. The first was just to establish a baseline length of stay for our endoscopic TSA patients using the Mount Sinai Hospital cohort. And we also wanted to look at or identify additional modifiable and non-modifiable demographic and clinical factors associated with prolonged hospital length of stay. Next slide, please. So for the methods, this is a retrospective cohort. We included all TSA patients from 2009 to 2020. We included only those with a histopathological diagnosis of pituitary adenoma, and we restricted our analysis primarily to macroadenomas. So we excluded all patients that had any sort of craniotomy, whether it was single craniotomy or stage with a TSA approach. We also just looked at adenomas and not any other cellular or supracellular pathology. Then we basically did standard analysis using chi-squared and student tests after stratifying our cohort into what we called standard length of stay, which was anything length of stay less than 72 hours, as well as a length of stay greater than 72 hours, which we called extended length of stay. Next slide. So this is a breakdown of our cohort. The average age was 56, BMI of 29. The majority of the cohort was female. And again, we only included TSA patients. Roughly a quarter of the adenomas were non-functional. The majority of them were secretory in some regard. I included the AP length here, but the transverse length for all of these tumors was 6.32 millimeters, so consistent with macroadenoma. And then the standard length of stay, or the average length of stay for these patients, was just shy of 72 hours or 3 days. We had 211 patients in the standard length of stay, and then 67 patients in the extended length of stay, so greater than 72 hours. Next slide, please.
1 minute, Noah.
Yep. So we saw that the average length of stay was roughly 68 hours, as demonstrated by this histogram. You could actually just go to the next slide. I already mentioned this. So this is a slide that's basically looking at various factors that we pulled from our database to see which is associated with extended length of stay. And the big finding here is that we saw that Black or African-American patients had slightly longer, or they had a higher odds of having an extended length of stay. Next slide. This is more of a slide that focuses on tumor parameters. So we saw that there were multiple parameters related to tumor size and volume that were associated with an extended length of stay. We also saw that postoperative DI, which we expected, was also associated with greater than 72 hours in the hospital. Next slide, please. So just to conclude the study, we saw that the average length of stay for our cohort was just shy of 3 days. Intraoperative CSF leaks, postoperative DI were significantly associated with the extended length of stay, along with tumor size and various other parameters associated with tumor volume, also correlated with extended length of stay. And as I previously mentioned, African-American or Black patients had slightly longer hospital length of stay compared to Caucasian patients. Next slide. So just looking forward.
Sorry, no, we have to cut it for time.
No problem.
Do you have a question before we move on?
I was just going to ask, Noah, thank you for the presentation. Did you perform a multivariate analysis to see if within that group of patients that had longer length of stay, there were any other characteristics that predispose them to a longer length of stay?
Thanks for the question, AC. So we haven't done that yet. That's actually, we have some multivariate models that I didn't share here, but that is something we're currently working on.
Thanks.
All right, so we'll move to the next presenter. Thank you, Noah. The next presenter is Zerubbabel Asfaw. He's sponsored by Dr. Germano, and he is presenting on the 2018 Lancet Global Health Commission and assessment of neurosurgical care in Ethiopia toward a high-quality health system.
Hello, I'm a rising third-year medical student at Sinai, and I'm going to present on an assessment of neurosurgical care in Ethiopia towards a high-quality health system based on the 2018 Global Health Commission report from the Lancet. And this was done under the mentorship of Dr. Isabel Germano. We don't have any conflicts of interest to disclose. So by way of introduction, Ethiopia is a low-income country in East Africa, right, located around the Horn. And the estimated total population is around 150 million. It's the second largest population in Africa, preceded only by Nigeria. And the estimated total number of physicians per 1,000 people is 0.1. So a bit on the background of neurosurgery in Ethiopia. We recently published back in 2020 that neurosurgery is a rapidly growing specialty in terms of the workforce. There were only 2 neurosurgeons back in 2010. And right at the time of this study, there were around 50 practicing neurosurgeons in total, with over 70 residents in training across 3 programs. And in 2018, the Lancet Global Health Commission published sort of the fundamental parameters of establishing a high-quality health system. And Ethiopia's Ministry of Health, among other countries, declared an initiative to track health outcomes, competence, and user experience in order to reach these goals. So for the aim and methods of our project, we wanted to evaluate access to high-quality neurosurgical care in Ethiopia based on the fundamental elements outlined by the Lancet Commission on Global Health. And these are the workforce, the physicians, numbers, skills, and support, the platforms to provide this care, the governance in terms of the insurance, health policies, and ancillary non-health sectors to support the care provided, and also the population's health needs and expectations, in addition to the tools that are required to deliver this care. So for our study, we ran a survey of all the neurosurgeons in the nation, and we compounded that by statistical and spatial analysis. So for the results of the study, we had a high survey response rate. 45 out of the 50 neurosurgeons responded, and most of them are between 30 to 40 years old. Most of them are men, although there are some few women in the training stages, and I think only 2 in the attending physician level. And 31 of them served in rural institutions, and we define rural as an area that contains less than 150,000 population. So for the annual number of cases per institutions, we found that most of the rural hospitals had less than 250 cases per year, and some mentioned that they had around 500 to 750 cases per year. In the urban hospitals, most of them had cases ranging from 250 to 750, while some of them had more than 1,250 cases per year. In terms of the programs with residency programs, hospitals with the residency programs have a higher caseload as compared to those without a residency program. And this is mainly due to the fact that based on the referral system, these institutions tend to be in the higher echelons. So they tended to have they were the most resourced and high-run institutions as compared to those in the rural areas. In terms of the most frequent neurosurgical conditions, the top 5 most frequent neurosurgical conditions were trauma, brain, followed by spine, tumors, hydrocephalus, spinal degeneration, and congenital malformations. In terms of access to neurosurgical care, so this was sort of the first time this was analyzed. Most of the physicians in the urban sector mentioned that most of their patients came to their care after suffering from trauma after traveling for more than 4 hours. And the reason we chose this 4-hour cutoff was that previous reports indicated that patients who suffer from neurotrauma could have better outcome if they ended up in the hospital within a 4-hour time window. In terms of ambulance utilization, most patients in urban and rural settings did not use ambulances. So ambulance utilization was low. In terms of population density and driving time, this shows sort of the location of hospitals in blue, superimposed with the population density in green, and the pink area is the 4-hour driving distance from each institution. So even though the institutions are sort of popping up all over the place with rising workforce, there's still huge swaths of the country that are without neurosurgical care. And this is the comparison multivariable analysis that still shows there is significant divide. And for concluding, the neurosurgical workforce is mostly comprised of men in early stages. The rural areas require more neurosurgeons, more pre-hospital care for trauma, and rapid access to urban centers. And all 4 components of the high-quality health system are in their early stages. So there needs to be continued investment in both workforce, healthcare, and basic infrastructure to reach that goal. And thank you for listening. And thank you to my mentor, Dr. Germano, and all those who contribute to this work.
Do you have any questions?
I would like to make a comment, beside the fact that this is outstanding work, Zero, that the reply to the survey was in the high 90s. I would like the audience to kind of make a note of this, because I think that for us neurosurgeons, a survey that is in the 90s is very remarkable. Congratulations, Zero.
Thank you.
Great, thank you. All right, we'll move to the next presenter, Neha Siddiqui, with faculty sponsor, Dr. DeLacy.
Hi, everybody. My name is Neha Siddiqui. I am a medical student taking a research year with Dr. DeLacy between my 3rd and 4th year of medical school. And our project is about the safety and efficacy of single stent aneurysm coiling techniques for wide neck bifurcation aneurysm, and in a multi-center core lab validated study where we're also looking at economic efficacy. So next slide, please. So traditionally patients prefer coiling to clipping just in terms of patient assessment of the surgery. You know, patients don't like having their brain open, but patients do prefer having a small incision in terms of having an intervention. And so patients tend to prefer coiling in that sense of patient satisfaction. And traditionally techniques for wide neck bifurcation aneurysms have been difficult in terms of coiling, and clipping has been the preferred traditional method. Some of the techniques that have been used on the left, for example, is T stenting, there's been Y stenting, and these techniques use 2 stents rather than 1 stent. And our study aimed to assess the safety and efficacy of L stenting, which is a single stenting technique, as described in the photo on the right here. So next slide, please. So just setting the groundwork here in terms of safety and efficacy, we conducted a core lab validated multi-center study and looking at the single stent assisted aneurysm coiling technique of L stenting in our setting of wide neck bifurcation aneurysms. Our study had 128 patients with an average follow-up of 16 months. Next slide. So our outcomes found that 10 of the 128 patients had serious adverse events, 7 had intraoperative adverse events, while 3 had delayed adverse events. And final MRS at follow-up was no change for 108, improved for 16, and worsened for only 4. Next slide. Our core lab adjudicated imaging data found that immediate post-procedure modified Raymond-Roy score was adequate in 73 patients, and at last follow-up was adequate in 110 patients. Next slide. And only 19 of our patients required retreatment, so that was 15% of the patients that were treated with the single stenting technique. So the significance is that this study found the first multi-center core lab validated data that supports safety and efficacy of L stenting in wide neck bifurcation aneurysms. But the next question becomes, how will this finding improve care? Next slide. And in the setting of patient care, a way to determine improved care is looking at efficacy. And in this sense, we are looking at cost effectiveness, which falls under this category. Next slide. So Dr. DeLacy and I decided to do a disease modeling state where we looked at how to model this disease long-term so that we could replace a clinical trial. And generally with these populations, it's very difficult to, because of small cohorts and other reasons, very difficult to begin a clinical trial. And so modeling would be a more primitive method to looking at outcomes before deploying a large-scale clinical trial. And so we modeled the disease state when an unruptured aneurysm is treated, this aneurysm can then rupture again, or just rupture the first time, or it can remain unruptured and need retreatment. It can remain unruptured and have no change in clinical functioning. A person can have change in clinical functioning for other reasons, or they can die of other causes. And if it ruptured, they can have all of the different MRS outcomes, and they can die of the aneurysm or die of other causes. Next slide. So we decided to do a simulation that would replace a randomized clinical trial and create a disease state model for both stenting methods using dual stent assisted coiling and single stent assisted coiling. And we calculated the odds of each outcome at 16 months using a Monte Carlo simulation where we sampled 1,000 times with the MSN package in R. Next slide. And so this is just describing using the same modeling matrix for both single and double stent assisted coiling. Next slide. And our findings were that the average cost of a stent assisted, or sorry, these were the numbers that we used for cost calculations. Next slide. And our outcomes were looking at net monetary benefit, net cost effective ratio, and quality adjusted life years. Next slide. So our 16-month simulation results found that 68% of the cases actually had a cheaper cost of single stenting techniques. And the mean net monetary benefit was found to be 18,000 with a standard deviation of 1902. And that standard deviation would go down based on the power of simulation and will change with each iteration. And in only 17% of the cases was dual stenting less expensive than single stenting. Next slide. So this study is limited based on, the data that we use for the study, and it inherits the innate limitations of any modeling data that comes from it, any literature that we use to produce that modeling data. So any of the studies that are cited, any robust long-term natural history data that is lacking, such as in studies such as ISHUA. If we get that data and it has its inherent limitations, that then is inherited by the model as well. So for long-term studies,
we're all out of time, Neha.
Okay, thank you.
Nice presentation. I'm actually going to move to the next one so we don't fall behind. But thank you for your presentation. Next up is Varun Subramanian with faculty sponsor, Dr. Kwan.
Yeah, good morning, everybody. My name is Varun Subramanian. I'm a first-year medical student, and I'm really excited to be presenting the work that I've done with Dr. Trevor Kwan. This is a population study looking at how the diagnosis of autism affects outcomes in epilepsy surgery. So before getting into the details and relevance of the actual project, I'd like to establish some context. So autism and epilepsy commonly co-occur, and recent studies have found that the period prevalence to be 12% of patients with ASD having epilepsy. This is much greater than previously reported estimates. 20 to 40% of patients do not respond to anti-epileptic medications and develop drug-resistant epilepsy. For these patients, surgical treatment is effective in providing seizure relief as supported by level 1 evidence as well as national guidelines. However, the underutilization of surgery is a well-documented phenomenon. Now, the reason for this is several, but it mainly is due to an improper understanding of when to refer patients to surgery and also what risks are involved. This hesitancy towards surgery is actually greater in those with autism and is largely influenced by previous literature. So very briefly, the first report of epilepsy surgery in an ASD patient was published in 1992. The patient was free of seizures after surgery and actually showed some abatement of autistic symptoms. Subsequent case reports and series also showed encouraging results. However, the narrative was complicated with the publication of 2 prospective studies, which suggested a limited effect for both VNS and resection in those with autism. So since then, several retrospective studies have demonstrated the effectiveness of epilepsy surgery, both in providing seizure relief and also in conferring some sort of cognitive benefit in this population. This is just preliminary data from a systematic review by our group of epilepsy surgery and autism. And of the 293 reported instances in the literature, 56 or 57% of patients showed greater than 80% reduction in seizures. So we know that surgery is efficacious, that's all well and good, but there still remains a gaping question. And that is it feasible? Meaning, are there barriers preventing providers or patients from considering surgical treatment? And to answer this question, we come to our present study. So we wanted to understand how the diagnosis of autism influenced epilepsy surgical outcomes and hospital level variables. So this included discharge status, in-hospital mortality, cost, complications, and length of stay. These outcomes were assessed in 2 cohorts. The first were those undergoing resective and disconnective procedures, and the second were those undergoing vagus nerve stimulation, which is the most common neuromodulation procedure in epilepsy. This is the first population-based study in the context of co-occurring epilepsy and autism, and our goal is to examine the trends of healthcare utilization and determine if surgery is in fact feasible for this population. So to do this, we use the National Inpatient Sample, which is a nationally representative database containing both information on patients as well as the hospital variables of interest. And we identified elective admissions for epilepsy surgery, as well as the autism diagnoses using previously validated ICD-9 codes. So each patient identified with both autism and epilepsy was matched to 3 patients with epilepsy alone as a control, and they were matched for age and sex. So then we performed multinomial logistic regressions to determine the actual effect of this comorbid autism diagnosis on the previously mentioned outcomes of interest.
1 minute.
So for VNS, we identified 52 patients who were matched to 156 controls with epilepsy alone. Same thing was done for resective surgery, which yielded 113 patients with both diagnoses matched to 339 patients in the control. And you can see based on the age and sex that they're nearly equivalent. So using these cohorts, we were finally able to answer the question of how the diagnosis of autism affects surgical outcomes. And the answer is that it really doesn't. there was no difference in any of the variables, discharge status, length of stay, cost, complication rate, or mortality in those with comorbid autism. And this was true for both resection and VNS. So why is this important? Why do we care about these numbers? Well, first of all, our population study demonstrates that epilepsy surgery is safe and feasible in those with comorbid autism. But also, compared to previous studies that looked at seizure freedom, cognitive outcomes, this is a separate but equally important dimension of evidence that supports epilepsy surgery in this population. So to conclude, diagnosis of autism should not be contraindicated for surgery, and appropriately selected patients should be referred because surgery offers a real potential to relieve the burden of seizures. So I'd just like to thank my mentor, Dr. Chilsu Kwan, and also Dr. Natalie Jate in the Department of Neurology, and also my seniors who helped me. So thank you all so much. I really do appreciate it.
Thank you, Varun. Do we have any questions? All right, we'll move on to our next presentation. Next up is Dr. Alshar Shai. She's presenting a project that she did with Dr. Penoff. Sarah, are you on? Oh, you're muted. You're muted.
Hey, sorry about that. Hey, my name is Zara. I'm one of the pre-residency fellows in neurosurgery. Today I'm presenting our initial data from the implementation project with Dr. Panoff. Just having trouble controlling the slides, Sukaina?
You can just say it, advanced slide.
Okay, that's good. Okay, so that's the picture that we tend to associate with meditation. Very ancient practice, at least 7,000 years ago. However, more recently, meditation has been incorporated into healthcare, and there is a robust evidence to support its effectiveness in the treatment of a variety of somatic and mental health conditions. And much more recently, there has been heightened interest in the neuroscience underlying meditation, and that was our question. Next slide. Does meditation change brain, and in which way? And there are several hypotheses driving our current project. The first is that meditation changes the default mode network, a very novel and interesting concept, basically describing our brain in the state of mind wandering. The second hypothesis is that meditation actually interacts with the epileptiform discharges in the brain and may change the threshold for seizure onset. And the other two hypotheses are more far-reaching. We're aiming that we will carry out this project to the point of building a machine learning algorithm to classify brainwaves as meditating versus non-meditating, and ultimately to also identify precise targets for therapeutic neuromodulation. These hypotheses have been previously investigated and described. However, the novelty of this study lies in the fact that the majority of the data that we currently have is extracranial data from surface electrodes or functional MRI. And there is very limited intracranial data. In fact, there has been one study that was published more recently from the University of Lyon by a French group who recruited 3 patients and guided them through hypnosis and meditation sessions. And our study is fairly similar in design to theirs. It's a non-randomized single central trial. The setting is mainly at the epilepsy monitoring unit at Mount Sinai West. However, there is a parallel project that we're running on our outpatients with RNS devices that's been perfectly coordinated by our excellent research volunteer, Leah, who's in the audience. We included patients who were obviously had drug-resistant epilepsy with implanted IEGs. We're able and willing to meditate, and we're aiming to use this data from initial sessions as their own active controls for both the short and the long term. The planned duration of the study is 2 years. So how did we actually conduct these meditation sessions? We always aim to get the patient in a private and a quiet room, minimize the number of personnel involved in each session, and instruct everyone to switch off their phones and try to meditate with the patient, which was proved very difficult for me initially. The first 5 minutes are spent to explain to the patient what the session entails and what meditation is, especially for novice participants. And then the next 10 minutes is guided focused attention meditation, preferably by our neuropsychologist, Dr. Sad. And then 2 minutes for mind wandering. And then we're hitting record for the IEG at each of these time points. Patients also fill the pre and post meditation questionnaires. And here's an example of our pre-meditation questionnaire that was also adapted by Dr. Saad. And then patients are encouraged to continue attending the meditation groups and to engage in our apps. And so far, we have recruited 3 patients in the EMU units for a total of 5 sessions. Our goal is to get at least 10 patients from the literature. This appears to be the number that will get us an 80% probability of detecting an effect size. And this is the, so let's go back one slide. So this is the spectrogram, as Dr. Chang pointed. This is the frequency on the y-axis, and then this is the timeline. This is start of meditation, 5 and 10 minutes.
1 minute.
This is session 1 and then session 2. And in session 2 here, you can observe a very interesting effect with increased gamma amplitude even before the start of meditation, because this patient is an experienced meditator, and we are hypothesizing that they were able to engage in that before meditation. You can observe a similar effect in patient 2, but less obvious. And in patient 3, there is a very interesting increase in brain activity here. This patient actually had a seizure, and we're currently investigating the relationship also between meditation and seizures, which is also very interesting. There's some MRI pictures. This is one of our patients next to a breathing wall. And thank you very much. We hope we gave you an idea of what we're doing. This is a work in progress with a timeline of 2 years for 20 patients. Here are some books if we got you interested in meditation. And this is Dr. Panov apparently meditating in the QLab with an RNS device. Thank you.
Thank you, Zara. Do we have any questions? Okay. So, while Sukhan is resetting the slides, we'll move on to our next speaker. It's Dr. Trevor Hartigan with faculty mentor, Dr. Chris Kilmer.
Sorry, just give me a second here. All set?
All right, great. Thank you so much, Sakina. Thanks, everybody. I'm going to get started on my talk on Interleukin-3 and its regulation of post-stroke hematopoiesis in mice and discuss some of the preliminary findings from the start of the study. So everyone here is very familiar with stroke in this audience, and there's obviously a lot of inflammation and other variety of factors that can influence the disease state. So in regards to neuroinflammation in stroke, the description of infiltration of immune cells into the ischemic brain in experimental models has been described within the last 30 years. But this is a very complex process that involves spatial temporal responses into different areas of the brain, a variety of cytokines that originate from both of the resident immune cells as well as infiltrating peripheral cells. In our lab, we've begun to look at this process, and it can be looked at, and we'll go through this quickly. This is a little complex, but there's a temporal process that goes from the early time point right immediately after stroke, leading into the resident inflammatory cell response within 1 to 2 hours. And then down the road, we have this peripheral infiltrating cells that then come in and start to link the innate to the adaptive immune response 1 to 2 days. And then this turns into a remodeling inflammatory cascade within several weeks after stroke. In our lab, what we've shown is that stroke has an impact on hematopoiesis and the regulation of the post-stroke inflammatory process. There's a differentiation of that process towards a myeloid pathway as opposed to a lymphoid pathway. So there's myeloproliferation after stroke, and this is correlated with increases in the proliferation of hematopoietic stem cells that correlate with infarct size itself, as you can see here, using representative TTC stainings, where the white is the stroke, and that correlates nicely with the inflammatory response that we'll see post-stroke. Using another model in our lab that looks at a particular cytokine IL-3, we were able to show in a chronic neuroinflammation disease state that the hematopoietic response and the inflammatory cascade is mediated by IL-3, as you can see in this representative plot here, and that the IL-3 itself is coming from peripheral cells, importantly, such as CD4 and CD4 positive T cells. So trying to put these two aspects together of stroke and inflammation, specifically IL-3 dependent inflammation, we proposed that ischemic stroke would be augmenting hematopoiesis and leukocyte generation in an IL-3 dependent manner, and that this would thereby increase inflammatory recruitment to the ischemic brain. And ultimately down the road, we'll be looking at microglial activity. So we took our both wild type and IL-3 global knockout mice. We performed a stroke in them, which I'll talk about in 1 second. And then downstream tests were looking at flow cytometry analysis of blood and bone marrow, as well as sections of the brain with TTC staining. So to do our stroke model, it's a ischemia reperfusion model that will open up a mouse here. We have the ECA, ICA, and CCA. We enter in the ECA by ligating it off. We thread a filament up after occluding the ICA here, thread this filament all the way up to the ICA terminus, which causes a stroke. And then after 45 minutes, we'll remove that filament and then tie off so that there is reperfusion from the CCA back to the ICA and up to the circle.
1 minute.
These are our cerebral perfusion showing that we had nice ischemia and reperfusion, that we have a standard infarct between the two different genetic models, such that we have no difference between our wild type or IL-3 knockout models. And our overall, these are our gating strategies for bone and blood marrow. And what we see here is that, similar to before, we have a decrease in lymphoproliferation and an increase in myeloproliferation that is attenuated in the IL-3 knockout mouse model, and both before and post-stroke. And so it looks like that earlier effect that we saw in the bone marrow is being mediated by IL-3. We also saw that this proliferation that was present in Ly6E high monocytes, so myeloproliferation was still present post-stroke in the wild type versus IL-3 knockouts. And in the blood, we saw an overall decrease in post-stroke IL-3 knockout monocytes, both high and low, as well as B19 positive cells, as well as overall monocytes and leukocytes. And what this suggests to us is that there's a very interesting process occurring post-stroke in these IL-3 knockout mice, where there is either increased trafficking to the brain, which we will investigate, or there's possible sequestration of those cells within the bone marrow. So trying to expand on this trafficking and process of post-stroke neuroinflammation that's controlled by IL-3 will be the next steps that we'll be undertaking in the lab. So thank you for your time.
Do we have any questions for Trevor? All right, thank you. We'll move on to Dr. Halima Tabani, who's presenting a project she did with Dr. Pano.
So again, the slides are okay. Good morning, everyone. My name is Halima. I'm one of the PGY2 neurosurgery residents, and I'm going to be presenting our study on the pre-residency fellowship program at Mount Sinai Hospital. So foreign medical graduates, or FMGs, comprise approximately 25% of the physician workforce in the United States. And recent studies have shown that only 8% of active neurosurgery residents and 12% of practicing US neurosurgeons are foreign medical graduates. A recent study out of UCSF between the years, looking at data from 2007 to 17, showed that the rate of matching of US medical graduates into neurosurgery increased by about 3.3 annually. However, that of foreign medical graduates remained unchanged. And there have been several recent studies looking at the trends of matching of FMGs into neurosurgeries, and they have shown that as compared to US medical graduates, foreign medical graduates have significantly lower match rates. They are more likely to take gap years. They have a significantly higher number of publications and H index and comparable test scores. But despite all of these statistics, they are less likely to match to NIH top 40 and Doximity top 20 programs. So this has significant implications on the lack of diversity within the workforce and also in longer term on access to healthcare and equity in the US and worldwide. So with this in mind, the pre-residency fellowship program at Mount Sinai Hospital System was established as a measure to bridge this gap and to provide foreign medical graduates opportunities to train clinically in the United States. The main aims of the study were to assess the characteristics and outcomes of the PRF program at Mount Sinai and to describe the objectives and structure of this program. So we conducted a retrospective review of the demographics and outcomes of the PRF program between 2016 to 2022. The program was established in 2016 initially at Mount Sinai West, but then evolved to include other sites, including Mount Sinai Hospital and Mount Sinai Morningside. And so far, we have had 12 fellows, out of which 3 are currently active. The main objective of the program is that it's a diversity program that's intended to provide a solid clinical foundation in neurosurgery to FMGs, but it has other far-reaching objectives, including advocacy for the representation of women in neurosurgery. The program is structured as a 1 to 2 year program, which provides hands-on clinical and procedural and operative training in neurosurgery. Amongst the 12 fellows that we have so far, 33% were females and the rest were males. And then this bar chart shows the baseline characteristics of the pre-residency fellows, showing that most of our fellows did not have any prior training in neurosurgery. About 17% were fully trained neurosurgeons from other countries, and then the rest had prior partial training in neurosurgery. In terms of the geographical distribution, the fellows originated from multiple different countries, including Spain, Thailand, Pakistan, and Ecuador. The overall success rate, which was defined as pursuing a successful neurosurgical career, either matching it to a neurosurgery residency or starting as a neurosurgery attending in the US, the overall success rate was 77.8%. Most of the 56% of the fellows matched into a neurosurgery residency program. About 22% joined the US workforce, neurosurgery workforce as an attending, and the rest matched into other subspecialties. And amongst the graduates who did match into neurosurgery, 40% matched into senior positions, while the rest matched in as PGY1 residents.
1 minute.
So to summarize our findings, so far, we do not know of any other studies which have looked at the outcomes of pre-residency fellowship programs in the US. There are about 6 or so established pre-residency programs in the US, and multiple studies have shown that having a pre-residency fellowship year or having prior neurosurgery training or neurosurgery affiliation in the United States is an important factor that determines the match rate of foreign medical graduates into neurosurgery. And our study being a single center study and having a small sample size has these inherent limitations. However, to conclude, the pre-RF program at Mount Sinai Hospital has had excellent success in providing foreign medical graduates an opportunity to pursue successful neurosurgical careers in the US. And it serves as an initiative to demystify the US medical graduate privilege phenomenon. Ultimately, our aim is to have more standardized neurosurgery resident selection criteria, which will have far-reaching effects on equity and diversity in neurosurgery and healthcare.
Thank you, Halima.
Thank you. Mm-hmm.
I had a question, actually. Do you think that if more programs adopted PRF programs that dilute the success of strong PRF programs like this one, in that having many more PRFs around the country might make it a more competitive environment?
I look at it as like the prelim general surgery program. So, there's several prelim general surgery programs. It's a well-established program in the US, which sort of gives both US and foreign medical graduates an opportunity to show their competence clinically by doing a year. So having multiple different PR programs would essentially, in my opinion, serve the same purpose, where they would give, especially foreign medical graduates, a platform to showcase their clinical competency and to show the programs that they are a good fit for the program.
Thank you, Peter. And a quick follow-up on that is right now, I think the main problem is access. So anything that increases access to these incredible individuals will help. And later on, we may hit a problem with quality, but I don't see it anytime in the future. So thank you, Halima. And to me, again, it's hard to change and it's hard to diversify our field. It really needs it. This program potentially helps to do it from the inside out.
All right, thank you very much.
Thank you.
We'll move to our next speaker. We have Jonathan Delea presenting a project sponsored by Dr. Shrivastava.
Am I muted?
Good morning, everyone. Thanks for having me. So I'm presenting our study today entitled ARID1A mutation associated with prior recurrence, shorter progression-free survival in atypical meningiomas. And I did this work with Dr. Shrivastava. Next slide, please. Okay. So as you may know, meningiomas have exceptional diversity in terms of mutational profile and prognosis, and even within specific WHO grades, there's variability in outcomes. There's been recent interest in the development of predictive models to classify and identify tumors with high risk for recurrence. As you might expect, prior recurrence is one of the strongest predictors that a tumor may recur in the future. With this in mind, we sought to further explore the differences in molecular genomics across primary and recurrent tumors. Next slide, please. So to do this, we utilized our institutional cohort, retrospective cohort, which contains a few hundred meningiomas. From this, we specifically selected atypical tumors that underwent a gross total resection, and all these tumors have been sequenced with a commercially available next generation sequencing program. We then compared the prevalence of commonly mutated genes across recurrent status. And then lastly, for a gene that we identified as more commonly mutated in recurrent tumors, we performed a survival analysis to assess the effect of that mutation on time to recurrence or progression-free survival. Next slide, please. So as you can see here a summary of the cohort. It's a total of 88 gross totally resected tumors, with the average age, in the mid to late 50s in both primary and recurrent tumors. But age, sex, and tumor location were not significantly different across recurrent status. Now on the right side of this, as you may expect, as previously discussed, previously recurrent tumors tend to recur much faster than the primary tumors do. Next slide, please. So in looking at just the genomics here, we identified, there were some differences in just a few of the genes that we looked at. Specifically, ARID1A was mutated at a significantly higher rate in recurrent tumors. Only about 7% of primary tumors did have a mutation in ARID1A, whereas 44% of tumors, of recurrent tumors, were in fact mutated in this gene. And this is a statistically significant result with p-value less than 0.01. Next slide, please. So then to assess the clinical relevance of this and the importance of this mutation, we looked at the effect of this mutation on recurrence. First, on the right, you can see the Univariate Analysis, where we demonstrated at the top here a 150% increase in the hazard of recurrence for ARID1A tumors. However, due to the potentially confounding relation or nature of the recurrence status, we then adjusted for recurrence status. And after adjusting for that, we identified there was no longer a significant relationship. However, as you might expect, recurrence status did become a significant predictor. So when you see, hazard ratio changing like this, it indicates there's probably some confounding there. So to address for that, we then included interaction term. Next slide, please. That assessed the interaction of recurrence status and ARID1A and their joint relationship on survival. As you can see here, there's a significant increase in the hazard of recurrence among primary tumors that happen to be mutant in ARID1A. However, in recurrent tumors, that increased hazard associated with ARID1A is already captured by the recurrence status variable. So there really is not any increase in hazard of recurrence for ARID1A tumors because they, previous recurrent tumors already have some, some mutation that confers their risk of recurrence, whether it be through an ARID1A or other mechanism. There's not a significantly increased risk over baseline for those recurrent tumors to happen to recur again. Next slide, please. So to further explore this, we then performed an analysis just stratified by recurrence status to assess the individual relationship of ARID1A to recurrence in both primary and recurrent tumors. And this again demonstrates that ARID1A tumors that are primary tumors tend to have a much, much higher, 620% increase in the hazard of recurrence. Whereas recurrent tumors, there really is not any difference in the outcomes for ARID1A tumors versus ARID1A wild type tumors. Next slide, please. So in conclusion, we identified ARID1A, which is the chromatin remodeling gene. We found that it's commonly mutated in recurrent tumors. We then found that this mutation is related to future recurrence in primary tumors. However, we didn't see this risk in recurrent tumors. And as previously discussed, all tumors that recur have some underlying propensity to recur. This may be mediated through an ARID1A mutation, or may be mediated through some other, other mechanism. And we found that ARID1A mutant tumors or ARID1A mutation may represent one such factor. And in the recurrent tumors, there are other factors that doesn't increase the risk. However, in a primary tumor, if ARID1A is mutated, there tends to be a faster time to recurrence. Next slide, please. So moving on to some possible treatment and clinical applications. Some studies have identified ARID1A as related to rhabdoid meningiomas, which is a pretty aggressive subtype of atypical meningiomas. And further study may validate this as a useful prognostic marker to guide treatment decisions. One such treatment decision that could be further explored is the use of HDAC inhibition, which modifies the chromatin remodeling pathway. There's some evidence in other cancers or in cancers that HDAC inhibition in combination with a checkpoint inhibitor does improve outcomes in ARID1A mutated ovarian carcinoma. So there might be some implication there for atypical meningiomas, where you think there might be an increased risk of recurrence for specific tumors.
Thank you, Jonathan. Do you have any questions?
I just want to add one comment to the research that John just discussed. What we found is interesting is from an analysis of a complex mutational profile that we've done, and this has been established, the ARID1A seems to be an important prognostic indicator for recurrence. And I think it's obviously not the entire story, of course, but there probably is, as John mentioned, a checkpoint inhibitor model, if we were to hypothesize one, that's related. So I think the finding of in itself and then the analysis of it is, I think, what's interesting. So thank you, John, for this work.
All right, so next up is Dr. Stavros Matsoukas with its faculty sponsor, Dr. Joanna Fifi.
Hello, everybody. My name is Stavros Matsoukas. I'm a research fellow within the neurosurgery department. My mentor is Dr. Joanna Fifi, and we'd like to talk to you today about the implications of the VIS-ELVO applications in the workflow metrics for large vessel occlusion in transfer patients within our Spokane system. Next slide. Next slide, please. So these are our disclosures. Next slide. So VIS-ELVO is an artificial intelligence-driven software approved by the FDA for large vessel occlusion in certain intracranial locations, namely the supraclinoid ICA and the M1 segment of the MCA. It has quite high accuracy metrics, including sensitivity of 93.8%, NPV of 99.7%, AUC of 0.86. And this data comes from a recent publication we had at JNIS. From our experience within our team, it facilitates early diagnosis, team communication, and treatment of large vessel occlusion. Next slide, please. So taking a step backwards, this is the Mount Sinai Spokane Hub system. This in the center, MSH, MSU, and MSW are certified by the Joint Commission to perform mechanical thrombectomies, and we get transferred patients from other institutions from two different groups. First of all, from Mount Sinai Spokes, that because they belong to Mount Sinai Health System, they have this available to process CTA scans of patients with suspected ELVO, including Morningside, Mount Sinai Brooklyn, MSPI. And then we also receive patients from non-Mount Sinai Spokes without this available, like Elmhurst, Bronx, Lebanon, and other hospitals. Next slide, please. So our null hypothesis is that the workflow metrics of transferred ELVO patients are equal between the Mount Sinai Spokes with VIS and the non-Mount Sinai Spokes without VIS. Next slide, please. Next slide. So we sampled our stroke quality improvement database, and we selected all the transfer patients between the period of January 2020, December 2021, so 2 years, with suspected or confirmed ELVO based on CDA. We formed two groups, again, the Vis transfers group from Mount Sinai spokes with Vis, and the non-Vis transfers group from non-Mount Sinai spokes without Vis. It's important to note that we did not compare the same centers before and after Vis, because that could introduce bias due to the overtime improvement of the centers. Next slide. So in terms of statistics, we use the R software, Shapiro-Wilk normality test to assess for normality. For categorical variables, we did frequencies, percentages, and chi-square. For normally distributed metrics, we reported a mean, SD, and independent two-sample t-test. The Levin's test was used to assess for equality of variances. For non-normally distributed metrics, we used medians, IQRs, and the Mann-Whitney sum test. And p less than 0.05 determines statistical significance. Next slide. And next slide. So these are the demographics of our study population. We can see again the Vis transfers group and the non-Vis transfers. 38 versus 40 patients, pretty much similar. All the baseline characteristics were comparable between the two groups and included median age, gender, ethnicity, percentage of IV thrombolysis, mechanical thrombectomy, baseline neurological status. Everything is comparable. Next slide, please. And this is essentially the results. We took every single possible time metric we could from peripheral CDA, including peripheral CDA to INR notification. As you can see, the first line, peripheral CDA to transfer call. If you look a little bit lower, peripheral CDA to transfer activation, peripheral departure to central arrival, to angiosuite arrival, to arterial puncture, and to recanalization. We also looked at peripheral arrival to peripheral departure, peripheral arrival to central arrival. Everything was statistically significantly reduced in the Vis transfers group. The only thing that's not statistically different here is the transfer time. And that's important, of course, because it shows us that the driving time from these two centers, from these two groups of centers, is the same. So it doesn't introduce bias to our results. So next slide. Next slide, please. So our conclusion, we do have evidence to believe that Vis elbow was associated with a decrease in all workflow metrics for elbow transfer patients within the Mount Sinai spoke and hub system, and therefore we reject the null hypothesis. Next slide. So thank you, and I want to thank you, my mentor, Dr. John Fifi, because without her, this project wouldn't be accomplished, and also Zucchini at the planning. Thank you.
Stavros, I have a question for you. Are there any other features that you may not have accounted for that could have affected things like transfer times or treatment times in the non-Vis centers, since they are not, most of the non-Vis centers are non-Sinai centers?
Yeah, so there is a possible bias that, the Vis centers are, by default faster than the non-Vis centers. I'm not sure that we can control for it in this analysis. We have some multivariable models to predict outcome based on Vis availability, but these are preliminary data, and we don't share in this presentation.
Yeah, I wonder. I don't know if it would be ethical, because Vis is we've found it to be so useful, but I wonder if you could design and get approved a prospective study where you took some of the Mount Sinai spokes and just took away Vis and then randomized them against each other. But something to think about for future study.
Yeah, I agree that would be interesting.
Okay, so next up we have Ali Vellani with research sponsor Dr. Haji Panayis.
Great, thank you so much. Good morning, my name is Ali Vellani. I'm a third-year medical student. I'll be applying into neurosurgery this upcoming cycle. Today, I'm going to be presenting some work that's currently in press on the application of machine learning for the prediction of prolonged length of stay following cervical spine surgery with a validation on a nationwide cohort of patients. So as a brief introduction, the advent of bundled repayment models has increasingly incentivized hospitals and physicians to improve outcomes while reducing costs. Prolonged hospital length of stay is associated with increased clinical risks and economic burden. As such, perioperative prediction of length of stay can be helpful to inform resource management, to improve clinical outcomes and reduce cost. So the goal of this study was to use machine learning to predict extended length of stay after cervical spine surgery and validate it on a national scale. In order to conduct this study, electronic medical records in the Mount Sinai data warehouse were mined to obtain perioperative features of about 4,400 cervical spine cases between 2008 and 2019. An ensemble decision tree algorithm was trained to predict extended length of stay, and it was ultimately validated on the large national inpatient sample containing over 300,000 cervical spine cases between 2009 and 2017. It's important to note that extended length of stay was calculated as the 75th percentile of length of stay in the Mount Sinai cohort, which amounted to 3 or more days post-op. So the algorithm exhibited high accuracy and generalizability with an AUC of 87% on the Mount Sinai test set denoted in blue, and an AUC of roughly 84% on the entire national inpatient sample, which is the red line. And we also assessed how well calibrated the model was in its prediction. Calibration curves for each cohort, both in the blue and the red, show that for every decile of predicted risk, the true probability of the outcome increased as we would expect. An interesting but unexpected finding was that despite our model being trained to predict a binary outcome, so here prolonged or non-prolonged length of stay, it was also well calibrated to predict length of stay on a more granular level on the order of days. And you can see at the order of 5+ days, it's still really efficacious. So that indicates to us that it's pretty resistant to outliers, and it can even detect quite prolonged length of stays. So these are some of this is the table of the overall statistical results. The overall takeaway here is that the model performs with high efficacy on tens of thousands of patients in both single center and national contexts. We also examined perioperative characteristics. The model found to be particularly informative in its prediction. This graph represents those results, where the y-axis here lists the top 20 most important features as determined by the model, and the x-axis shows how the distribution of those features affects prediction. So for example, surgical approach was found to be the most predictive feature, with anterior approach represented by the red hue here, correlating with lower likelihood of prolonged length of stay. The relationship between many of these variables and length of stay is something that we see in practice, but that lends confidence in the ability of the algorithm to derive meaningful insights. I think some of the things that were not so readily apparent were the nonlinear feature effects and how they impacted length of stay. So the graph here shows how age and surgical approach interact to impact probability of length of stay. Although age and non-anterior surgical approach independently predict prolonged length of stay, elderly patients who underwent anterior cervical fusion were more likely to experience extended length of stay than those who underwent non-anterior cervical fusion. We found similar interesting nonlinear interaction effects between anterior approach and admission status. We also saw that between ethnicity and gender, and also comorbidities and gender as well. So this was just a sampling of some of the interaction findings that we found. So, I provided thus far a high level findings at the cohort level, but patient level assessment really allows us to deliver personalized care. So the plot over here generates, shows like a random patient in the Mount Sinai cohort when the model correctly predicted to undergo prolonged length of stay. We can visualize the factors that the algorithm used to guide management. So here it was specific factors such as hypertension, older age, history of substance abuse. Those were the drivers to predict prolonged length of stay in this patient. Whereas for this patient who was correctly predicted to undergo non-prolonged length of stay, there were other factors in blue that were identified. Using this similar analysis, we can also look at false positives and false negatives to see where the algorithm makes mistakes to kind of guide improvement moving forward. So in conclusion, our machine learning algorithm was able to predict extended length of stay after cervical spine surgery with high accuracy on both internal and external validation. Algorithm assessment can be used to identify drivers of prediction to unravel the black box of machine learning and to lend confidence in predictions. So just wanted to wrap up by thanking my co-authors and my mentors, Dr. Orman, Dr. Creedy, Dr. Steinberger, Dr. Hadjipanais. I had the privilege to work with them and learn from them. I received their support and guidance, which made this work possible. I'm happy to take questions. Thank you so much.
Thank you. Do we have any questions? Okay. All right. Thank you, Ellie. We'll move on to our next speaker, Haley Ronk, with faculty sponsor, Dr. Raymond Young.
Thank you. So my name is Haley Ronk, and I'm a rising fourth-year medical student here at Sinai, working in Dr. Raymond Young's lab. And today I will be presenting our project on volumetric whole brain tractography. Let's see, I can't advance, so next slide. Thank you. Gliomas are malignant tumors derived from glial cells or their precursors. In the United States, these tumors constitute the majority of all primary intraaxial central nervous system tumors. For nearly 2 decades, the standard of care treatment for high-grade gliomas has consisted of maximal safe surgical resection of the tumor, followed by concurrent temozolomide chemotherapy and radiotherapy. A major challenge for neurosurgeons is the balance between minimizing residual tumor volume and preserving eloquent brain regions. Thus, the optimal extent of resection for any given patient is often less than 100% of the tumor bulk. Previous works have demonstrated that an extent of resection of at least 78% are predictive of a significant patient survival advantage. Meanwhile, other works have demonstrated that aggressive resection in eloquent brain regions, which leads to surgically acquired neurological deficits, is associated with a significant decrease in survival. While many studies have focused on the minimal extent of resection needed to improve patient outcomes, few studies have examined the upper limit of surgical resection. To date, there are no accepted methods of assessing the upper limit of resection. Here, we developed a predictive model for surgical outcomes in a high-grade glioma and leveraged it to determine the utility of a whole brain tractography-based resectability metric. Next slide, please. In this study, we examined patients who underwent biopsy or resection of a new or recurrent high-grade glioma by the senior author from 2013 to 2020. We utilized retrospective chart review to gather data on surgical outcomes and disease progression. BrainLab software was used to determine the extent of resection and residual tumor volume from pre- and post-operative MRI data. Whole brain tractography was then generated from diffusion tensor MRI images. Next slide, please. In this study, a total of 151 high-grade gliomas were identified. The median extent of resection for all patients was 97%, and the median PFS, which we defined as the time from operation to unequivocal size increase in tumor with gadolinium enhancement on MRI, or increase in tumor grade on subsequent biopsy, or a significant decline in functioning noted by a clinician in the patient's chart, was 5 months. Next slide, please. First, we observed that the 2021 integrated WHO CNS5 classification system was significantly predictive of PFS, as there was a clear separation of the survival curves by tumor type. In contrast, IDH mutation status and tumor grade on their own were not independent predictors of survival. Next slide, please. We also observed that a greater EOR was associated with a significant PFS advantage. We found the most significant EOR threshold occurred at 85%. Next slide. Consistent with the literature, greater EOR strongly predicted longer PFS. Unexpectedly, when controlling for EOR, higher residual tumor volume predicted a longer PFS. These data suggest that the relationship between EOR and PFS is likely nonlinear and contains a critical point beyond which further resection is detrimental to the patient. In line with this hypothesis, involvement of eloquent brain regions in the brainstem predicted a lower EOR due to surgical sparing of these areas, yet involvement did not predict a shorter PFS. Overall, these observations suggest that variables beyond EOR are likely important in best predicting patient outcomes. Next slide, please. Finally, we were able to successfully use our whole brain tractography models to calculate unresectable tumor volume for a subset of pilot patients. Interestingly, we found that we could apply the whole brain tractography models to a patient when the tumor prevented tract modeling by using the contralateral tumor-free side, and could also be applied when a tumor lacked the necessary imaging to create a tractography model by using patient-matched controls. An example of one of our models is shown here on the right. Yellow highlights the dominant arcuate fasciculus, while blue represents the corticospinal tract. This patient had a left-sided tumor that obscured tractography mapping, so mapping was performed in the right hemisphere and flipped to the left. Our model was also able to incorporate deep brain and midline structures. Based on the tractography data, we were able to calculate both absolute tumor volume involved in critical structures, which we called unresectable tumor volume, and the percent of the total tumor volume that was unresectable. Given our multivariate Cox regression analysis, we hypothesized that, similar to total EOR, there may also be a threshold for UTV. For example, since we found that the most significant EOR threshold is 85%, we might expect to find the threshold for UTV lies around 15%. In the future, we plan to expand our analysis of UTV and incorporate this new data into our multivariate models. Next slide, please. In conclusion, we found more aggressive EOR strongly predicted longer PFS, but controlling for EOR for tumors located in critical brain regions showed that sparing of eloquent areas did not reduce survival. These data suggest that the current methods of measuring high-grade glioma resectability are poorly reproducible, have limited generalizability, and do not independently predict survival. Thus, preoperative measurement of UTV based on whole brain tractography may greatly simplify surgical outcome prediction and allow neurosurgeons to better determine surgical candidacy and goals. Next slide, please. So this concludes my presentation, and here are my acknowledgements, and I'd like to thank everyone from the lab. Thank you. I'll accept any questions now.
Hey, Haley, nice job. Quick question. Did you guys look at all at supramaximal resection of tumors?
I believe there were only a handful of instances where we had supramaximal resection. And I don't remember those results quite off the top of my head, but there might have been maybe, I think 5 to 10 patients that I easily remember out of our entire 151 subset.
Yeah, and then the other thing is, you know, all these tumors have non-enhancing portions of tumor. So how are you going to account for that in this model of unresectable tumor?
Yes, that's definitely a challenge. We incorporate both T1 and 2 MRI images in order to determine the tumor volume, but there's definitely areas that we're likely missing when we're calculating unresectable tumor volume. So that's definitely an area that we'll need to work on when we're adding more patients beyond just our pilot study in order to improve the prediction and make sure we're as accurate as possible.
Nice job.
I may have missed it, Haley, but did you also control for molecular characteristics of these tumors?
We did actually. From 2013 to 2020, we had a wide range of molecular characteristics, and nothing was particularly striking. IDH mutation status, again, was predictive of survival, but not on its own. So we found the new 2021 CNS5 classification system is actually the best, most simplified method of predicting patient survival based on tumor rather than any specific individual mutation.
Great, thank you.
Yes.
Okay, our next speaker is Michael Martini, who is presenting a project mentored by me.
Okay, good morning, everyone. Thank you very much for the opportunity to present, and thank you very much to Dr. Chang as well for an outstanding lecture this morning. My name is Michael Martini, and today I'm going to present on a project that we've been working on with the team for a little over 2 years now during the course of the pandemic, looking at the student perceptions and outcomes of a didactic course geared towards medical students in the setting of limited educational opportunities during the pandemic. Next slide, please. So as we all know, rotating sub-internships are a critical portion of the learning experience for medical students deciding to apply into many surgical subspecialties, including neurosurgery. It's both a chance to learn about a new department, learn about the field of neurosurgery, and also for other individuals in neurosurgery to learn about the student as well, and a chance for personalities to kind of mesh together. Of course, during the COVID-19 pandemic, in 2020, I'm not sure, can we go back a slide, please? Thank you. In 2020, these sub-internships were suspended, and in 2021, they were reintroduced in a limited capacity. In response to these limitations in 2020, our department did develop a didactic course geared towards medical students to help them develop a new learning resource that could kind of fill in some of the void that was left during the suspended sub-internships. And over here on the right, you can kind of see how this course was structured. Typically, the didactic course would begin with topical information in a lecture style, and then afterwards it would become a little bit more interactive with case studies to kind of assess student understanding and reasoning. In 2021, we continued this course as well and kind of revamped it. So next slide, please. And so this is really a survey-based study. The methods are fairly simple, but basically the course went on weekly for 1 hour each week over a 3 to 4 month period spanning about late spring to early fall. And before the course even started, all participants who registered were sent a fairly comprehensive survey asking them to rate their backgrounds, their experiences in neurosurgery, as well as their baseline confidences in several core concepts in neurosurgery. And you can kind of see a section of the Google form survey that was sent out over here on the right. Next slide, please. And similarly, after all the lectures had been completed, participants were also sent post-course surveys, similarly to assess their confidence in these same topics again. And you can see that over here on the right, these are the types of questions that were asked, the confidence on a scale of 1 to 10, and student responses were analyzed in a pairwise fashion and compared across course years for this analysis. Next slide, please. So here are the general results. So you can see here that the course actually did reach a fairly wide and diverse audience, attracting students who are both traditionally underrepresented in medicine, as well as those both in attending medical school, both in and outside of the United States. In general, across the cohorts of 2020 and 2021, we did see a slight drop-off or a decrement in the number of responses that we received, but the student population actually was fairly consistent in both years. The one slight difference to note is that in 2021, it appears that we did attract a slightly younger audience with more students in the earlier stages of medical school or even pre-med compared to in the 2020 year when most of these students were more senior medical students. Many of these students were also fairly confident that they were going to be applying into neurosurgery anyways, suggesting that this is a fairly self-selecting audience who decided to participate. Next slide, please. So this first piece of evidence or results that I want to present to you today are the course quality ratings. So we asked every student on the post survey how they felt the course was in terms of the value that was provided to them, as well as the clarity and the content of the slides, as well as the style of the lecturer, various different domains in terms of evaluating quality. And you can see here when it was split across all the different subfields of neurosurgery that we looked at in both 2020 and 2021 on a scale of 1 to 5, the ratings were very consistently high, suggesting that the participants really felt that the course was of high quality. Next slide, please. And these are the results for the self-assessed confidence. Again, we assess confidence at baseline and again after the course. And breaking this down again by year and by subfield, you can see that there's a significant increase in the confidence in various core topics in various subfields of neurosurgery. And similarly, if you look at the composite down below, you can see that most students feel, a mid-level value for confidence, and then by the end of the course, they experience a significant increase in their confidence across all these topics. Next slide, please.
Out of time, can skip to the end.
Okay. All right. So in conclusion, basically we received very positive feedback for this course. Student confidence was significantly increased before and after for both years. And this suggests that there's an ongoing value to a didactic curriculum that maintains even despite when in-person rotations resume for medical students. And as you can see here, there's a quick screenshot of the Mount Sinai Neurosurgery YouTube page suggesting that these resources are available for future students to continue to use. Thank you for your time.
Thank you, Michael. Do we have any questions? Just add that Michael really drove this work. We put together the course, but he did all of the work in making these surveys and trying to get the results in. So thank you. Go on to our next speaker. We have Dana Klavansky, Dr. Dana Klavansky, who is mentored by Dr. Spiridou-Letsetsu.
Yes. Good morning, everyone. Thank you for having me today. So yes, I'm Dana Klavansky. I'm one of the Neurocritical Care Fellows, and today I'll be discussing a multimodal, non-invasive approach to predict radiographic DCI in high-grade aneurysmal subarachnoid hemorrhages. Next slide, please. And I have no disclosures. Next slide. The content for today's talk. So I'm going to be giving a bit of background. Then we'll go through the methods, the results, and a brief discussion. Next slide, please. So for a bit of background, so aneurysmal subarachnoid hemorrhages, as we know, are a devastating form of hemorrhagic stroke. 25% of patients develop progressive neurological deterioration and silent infarct within this 4 to 14-day window, which is referred to as delayed cerebral ischemia, or DCI. DCI itself is a complex secondary brain injury pattern whose pathogenesis we unfortunately don't fully understand still, and early identification continues to be challenging. It's also a major cause of death and disability. There may be an associated radiological infarct, and those with radiographic evidence of ischemia have been shown to have worse outcomes. There have been prior small studies that have proposed criteria for predicting DCI. These have been based on changes in continuous EEG features, like decreased alpha delta power ratio or relative alpha power variability, in addition to epileptiform discharges. A recent study also showed that epileptiform activity in conjunction with high MCA velocities, in addition to, was significant in predicting DCI. And the Hunt and Hess score on admission and aneurysm treatment were the best predictors of DCI. But unfortunately, the populations have been limited and the studies were all retrospective. Therefore, we can't identify in real time that these patients were undergoing vasospasm. The two modalities that we use in the unit are EEG and TCDs. The EEGs have been a mainstay method for evaluating comatose subarachnoid patients to detect critical changes in their brain perfusion. And TCDs are another non-invasive modality that we use to assess cerebral blood flow velocities, and it can be useful to detect vasospasm after a subarachnoid hemorrhage. In this study, we did the transtemporal approach for these TCDs. Next slide, please. So our aim for this study was to identify an early, meaning prior to day 7, multimodal approach prediction model for cerebral infarct and radiographic DCI in patients with severe aneurysmal subarachnoid hemorrhage. We looked at multiple parameters, but the significant ones for the sake of this talk are epileptiform activity, the alpha delta ratio, and the Lindegard index. And therefore, we hypothesized that the combination of continuous EEG characteristics and TCD values would improve early DCI prediction accuracy. Next slide, please. So for our methods, this was a single group prospective observational study. We kept our inclusion criteria quite broad. The patients just had to be greater than 18 years old, have a non-traumatic high-grade aneurysmal subarachnoid hemorrhage admitted to our unit, and they had to have simultaneously completed EEG and TCD studies. We also collected a multitude of demographic, clinical, and neurophysiologic. And therefore, we made our primary outcome the prediction of DCI within the first 21 days from onset of their subarachnoid hemorrhage. The statistical analyses we used were the Fisher and Matt Whitney U tests with a p-value set at less than 0.05. And we did logistic regression and forward stepwise selection to determine EEG and TCD predictors for DCI. Next slide, please. So since this is a pilot cohort, we just do have only a few patients. We've had 10 selected patients so far since we started the study, and we included 8 of them. So the significant things from what we can see here are, so far we found that their MRS at discharge, there has been a significant p-value between those who had a DCI with a radiographic infarct and those who did not have radiographic infarct. Otherwise, the CPC, which measures their physical and neurological outcomes upon discharge, it was not significant. The alpha delta ratio so far, less than day 7, was not significant, and neither was the epileptiform presence before day 7. Next slide, please. And this was to look at the prognostic value of the multimodal model that I mentioned prior that we came up with of the 3 variables before day 7. So this was the increase in the Lindegard index, epileptiform abnormalities, and a significant alpha delta ratio reduction. And we found that while the sensitivity was not significant, there was 100% specificity and therefore 100% positive predictive value for these 3 factors that we chose. Next slide, please.
1 minute.
So therefore, we found that these early multimodal predictions of DCI with radiographic infarct is reliable. We utilize these 3 parameters, and we intend to, of course, include more patients in the study to see if we find any other factors. This is still a pilot study, so we're obviously recruiting more patients, and it's, of course, IRB approved. Next slide, please. As I said, the limitations are that this is a small study, so we're actively recruiting new patients. Quantitative EEG is necessary, so we need to ensure that it's included in the continuous EEG when the patients are hooked up. That's why we had to exclude 2 of the patients. And TCDs have to be done usually by the same operator in order to avoid variability. So I've been doing all the TCD studies. Next slide. So I'd just like to thank Dr. Tsetsu, Dr. Yu, and Dr. Haiyang Bang for their input and their insight to make this project possible, in addition to the MSH and ICU staff. I'll take any questions. Thank you.
All right, do we have any questions? Okay, so next up we have Thomas Featherston, who is mentored by Dr. Hickman. You're muted, Tom.
Sorry about that. Aloha and good morning, everyone. I'm Tom Featherston. I'm calling in from Triple Army Medical Center in Hawaii, where I'm a PGY1 in emergency medicine. And today I'll be talking about our work with the cost effectiveness of topical vancomycin in cranioplasty with Dr. Hickman and Dr. Jones. So for a little bit of background, cranioplasty complications bear enormous costs, both in terms of financial burden, but also on the patient as they delay neurological outcomes and cause significant cosmetic and psychosocial stress. Topical vancomycin powder prophylaxis has enjoyed significant success in various orthopedic surgeries, specifically shoulder and knee, which we'll reference later. And this is significant because primary cranioplasty infection can range anywhere between 3.9% to as high as 33%, depending upon the patient population and how many times the patient needs revisions. Of note, infection is the leading cause of cranioplasty failure at 53%. And of those cranioplasty failures caused by infection, 66% or more end up requiring a complete revision where we actually have to scrap the original implant and we have to go in at a later date. So in order to develop our methods and kind of get a lay of the land, we ended up doing a review of the literature where we looked at the cases and the overall infection rate as well as causal organisms. And we found that the weighted average of infections ended up being around 8%, with the leading causal organism being MRSA. And this is significant because if we're talking about topical vancomycin, as all you guys remember from Sketchy Farm, et cetera, this means that 76% or more of the found organisms during our review are susceptible to vancomycin. So the aim of our study was to compare the infection rates across with costs associated with infection, and we ended up believing that the prophylactic use of topical vancomycin would be cost effective. In order to do this, we conducted a break-even analysis where we took the total number of surgeries, costs, the initial infection rate, and we reorganized it with the final infection rate to determine the absolute risk reduction that would be necessary for a cost-effective surgery, wherein topical vancomycin costs would be outweighed by the cost of revisions. So for this, we identified 3 chief practice patterns, whether that's you just got IV antibiotics, whether you ended up requiring a washout with the implant being saved, or whether you needed a complete revision. And from there, we ended up querying hospital data sets, and we were able to identify costs with min-max results based on the time course in terms of stay, as well as operative implants used, the cheapest being titanium mesh. So for our results, we ended up finding that the break-even absolute risk reduction necessary for our price point here at Mount Sinai was about 0.007. So that means if you reduced or if you eliminated 1 out of every 1,400 infections, not cases, vancomycin would be cost effective. Additionally, we found that if you ended up changing the infection rate, this doesn't change because of just how the math works out. And then furthermore, if you actually reduce the cost, assuming you could get a cranioplasty as cheap as $500 US, that you would only have to reduce the infection rate by 0.28%. And then we ended up comparing this with our practice patterns here at Mount Sinai, wherein 16% end up going through treatment course 1, 18 treatment course 2, 66% treatment course 3. And we found that you would end up having a savings of $909,000 or $900,000 per 100 operations if you use prophylactic vancomycin.
1 minute.
Yep. So in conclusion, current clinical trials at Weill Cornell and New York Presbyterian have indicated that topical vancomycin is safe with minimal adverse events. These are typically seromas, but they generally don't occur at a significant rate higher than the general population. And we have shown that these have been, and that this has been shown to reduce infection rates. Infection rates have been brought down in some studies of pediatric cranioplasty from 11% down to 0.5%. So taking all this in, prophylactic topical vancomycin is cost-effective across a broad range of costs and practice patterns and can likely reduce financial burden of such infections. Here are some references. And again, thank you, Dr. Hickman and Dr. Jones for your time, and thank you all.
Tom, it's a really nice talk. I'd be interested in whether this effect extends to other procedures where the infection rate is already lower at baseline, things like shunts or instrumented spine. I know that there's been some data published on that.
Yeah, there's intermittent data for spine procedures that we've seen that has shown some effect, but it's currently limited and it's generally done as case reports.
Thanks, Tom. Great job.
All right, so we'll move on to our next speaker, Colton Smith, who is mentored by Dr. Kellner.
Hi, everyone. My name is Colton. I work with the research team as a clinical research coordinator. Today, I'll be discussing the feasibility of use of a portable stroke detection device within the acute stroke code workflow here in the Mount Sinai Health System. Thank you. So as many of you know, over the last decade, research, much of which was actually conducted here by our faculty, has demonstrated that minimizing time to treatment for large vessel occlusion results in significant improvement in long-term functional outcome. Now, research is just starting to emerge on whether or not recovery from intracerebral hemorrhage intervention is also time dependent, but regardless, it's still important to perform these rapid diagnostic assessments for acute stroke workflow to minimize this time to treatment, whether it be ICH or ischemic stroke. So one way that this process can be streamlined is by using portable stroke detection technology. The Cerebrotech Visor is an example of this. It's an FDA-cleared portable stroke detection device that is easy to use, allows us to rapidly assess bioimpedance asymmetries in the two cerebral hemispheres to aid in neurologic diagnoses. Now, a few years ago, Dr. Kellner and his team published a paper called VITAL, where the device proved the ability to differentiate between minor and severe strokes, as well as severe stroke from all other subjects included in the study, whether or not they had other brain pathologies or were healthy controls. Now, how does it work? The Cerebrotech Visor system uses what's called VIPS technology, that is volumetric impedance phase shift spectroscopy. And if you take a look at the diagram here, when the device sits on the patient's head, there is a detector and a transmitter that transmits a low frequency radio wave from the front to the back of the patient's head. And when that happens, it provides a ratio of the difference in fluid between the two hemispheres. Now, this is dependent on the idea that with a severe stroke, especially LVO, one side of the brain will have more blood volume than the affected hemisphere. So what we want to do is build on the VITAL paper and see how this device actually works within our own health system's acute stroke workflow. So we scan patients from March through June 2021 across 3 of our sites, Mount Sinai Hospital, Mount Sinai West, and Mount Sinai Queens, when a stroke code was called either in the ED or in an inpatient ward. In some instances, the patient had already been transported to the CT scanner or made it to the angio suite and then thus were scanned here. We collected some QA metrics, including the time required to complete the scan, where the scan was performed, and if there were any difficulties related to device placement, any patient discomfort or pain. Patients were not scanned if they had any intracranial hardware or jewelry, which could have influenced the signal quality from the device, or if they had any unremovable head dressings. Over the 3 months, we scanned 63 patients on an average of 53 seconds, which is under a minute. That's pretty good time. One patient was not scanned due to a head dressing. 4 patients did not tolerate scanning because they were confused and combative to the actual user placing it on their head. And less than 5%, the user noted difficulties placing the device due to hair. And about 8% of the scans, the device actually prompted a rescan because the patient was moving. Nearly every subject was compliant and tolerated the scans. No individual reported interruption to the acute stroke workflow, which is very key. As you can see on the left, the vast majority of our scans were performed in the emergency department, with about equal numbers in an inpatient ward and at the CT scanner, and very few of our scans were performed at the angio suite prior to intervention. So what can we say about it? The study shows the device is feasible in the clinical setting. It provides results in less than a minute with minimal disruption to the existing workflow in the stroke workup. So ultimately, we believe this device can be incorporated into the acute stroke triaging workflow without impeding the current standard of care. Here's some references from the introduction, and just want to say thank everybody for the opportunity to present today.
Thank you, Colton. It looks like Stavros, you have a question?
Sure. Hey, Colton, great job. I just wanted to ask, how do you and your mentor envision that this device could be implemented in clinical practice in a way that it can actually decrease the time metrics that we already have by doing the CT and CTA? How can we either substitute one of these two, or, you know, in any way, can we decrease the time to diagnosis and time to treatment by implementing this device in clinical practice in the future?
So that's a great question. So obviously, in the existing workflow, the CT, CTA, CT perfusion is a gold standard for assessing and truly diagnosing what's going on with the patient. However, if we can get the patient scanned, maybe in the ambulance or in the ED, as we were able to in this study, maybe we can bypass the CT and get the patient straight to intervention, where they can get an intraoperative dyna CT or get them to the bed and do a diagnostic angiogram right off the bat and skip the line of waiting in the CT scanner, because as we know, that adds quite a bit of time sometimes in the acute stroke workflow. So I think that's where it can really hit home, is before a patient even has to go to a scanner, maybe get them straight to the table.
Great, thank you.
Nice presentation, Colton, and nice answer. I completely agree.
Thank you.
All right, so this will be our last poster presentation, our last oral presentation before we move to the next hour for posters. This is Dr. Schuper presenting a project with his faculty mentor, Dr. Hartigan. Alex, we can't hear you. You have no audio.
Is he muted?
Yeah, no, Alex.
Hey, you can.
Now we can hear you.
So sorry about that.
Okay.
That's right. Can you hear me now?
Yes. Yeah, you didn't have a microphone earlier. Go ahead.
Wait. Hey, can you hear me? No. Yes, we can. Now you can. Okay. Yeah, I apologize. Sorry about that. All right. So let me go back for a second. Okay, sorry, the slides are a little delayed here. Again, my name is Alex. I'll be presenting a project I did that we're currently working on with my mentor, Dr. Hartigan, on a handheld Raman device. So everyone here is familiar with the story of gliomas, specifically in high-grade gliomas. We know from the work of Nader Sinai back when he was at UCSF, as well as others, that with complete resection of the contrast-enhancing tumor, that there is a progression and overall survival benefit. However, we know that the story doesn't end here, that if we look further into these tumors, we know that there are invasive tumor cells that extend beyond the contrast enhancement region that we see on MRI here. And we know that because almost all recurrences are local and they occur within 2 centimeters of the resection cavity, this creates a need for us that limits devices such as intraoperative MRI and ultrasound in the ability to improve our ability to visualize and detect tumor cells to maximize safe resection in the operating room. So this introduces a technology that's actually very old. It's been around for over 120 years. However, in the field of neurosurgery, it's relatively new. It's only been around for around a decade or so, called Raman Spectroscopy, which the science in itself is not very advanced in that it utilizes the low-powered near-infrared laser to directly illuminate tissue. And then this fraction of light after reflecting off the tumor exhibits a specific wavelength shifting in pattern known as a Raman shift. And so the vibrational frequencies of the light as it reflects, as it interacts with the target tissue, creates a spectral pattern. And it's similar to a finger tissue has a unit, and it creates a certain identification for different types of molecules and of tissue substances that we can see here. And so we can use this to our advantage by being able to differentiate between tumor tissue as well as healthy brain and differentiate different types of tumors. Sorry, the slides are not advancing. Oh, there we go. Okay. So we'll see if the video works here. Oh. Sorry, the slides do not seem to be working very well. Try to go back. Apologies, there's like a 30-second delay on the slides. So here we utilize a handheld optical probe by a company called Reveal Surgical, which creates real-time Raman spectroscopy measurements. And then there are several advantages to this technology. It allows us to utilize this probe in a non-labeled manner without any contrast injected into the patient. And as I previously described, having this unique molecular fingerprint for the tissue allows us to provide, it provides us with diagnostic information in real time. We don't have to wait for a tumor sample, a frozen, to be sent to a neuropathologist. We're able to obtain information about the target tissue in real time in the operating room. And so then we can take that one step further and use advanced machine learning algorithms to more accurately identify the target tissue and determine what type of tumor that we're looking at. So there have been previous studies by McGill University in Canada. However, in the first US prospective study, we tried to use this device. It's so far only being used here in Mount Sinai with Dr. Hartigan, and the goal is to differentiate between tumor tissue and surrounding normal parenchyma. So as part of this study, which is still ongoing, we're collecting samples of both tumor bulk, the margin, and the surrounding healthy parenchyma. And then we're correlating these tissue biopsies with histopathological samples with our neuropathology team. And for the purposes of this study, we used we looked at high-grade gliomas, metastases, as well as meningiomas. Sorry, waiting for the slides to advance. So in our initial sample of 15 patients, we looked at 3 patients with glioblastoma, 9 with metastases, 3 with meningiomas. And what's interesting here is, as you'll note, there are spectral pattern differences, not just between GBMs versus METs versus meningiomas, but in specific areas within the tissue and in the brain, in the invasive margin. And by using AI modeling, which we don't have time to discuss for the purposes of this talk, the models are able to differentiate between specific regions of the tumors as well as tumor type. And so in a validation study where we compare controlled versus tumor samples across all tumors, we had an over 80% sensitivity and specificity. And looking just at metastases, this was 91% specific and 85% sensitive. And so this is some of the initial data of a larger multi-center study between us and McGill, which we'll be looking at 100 patients to better assess this technology and how we can provide real intraoperative information into tumor classification. Thank you very much for your time.
Thank you, Alex. Do we have any questions? Stavros, I see your hand up again.
Yeah, so this is very interesting, obviously. Do we have any status to know how this compares to ALA?
Yes, that's a great question, Stavros. So we're looking at several different portions here. We're looking at many different types of tumors. We know that in the case of 5-ALA and other fluorophores, they tend to be more sensitive when it comes to high-grade gliomas, but have less of a robust response when it comes to metastases when you look at them as a whole. They're more specific for certain types of Mets. But 5-ALA does seem to be pretty responsive to meningiomas. We do know that the actual intensity of the fluorescence varies based on whether you're at the tumor core versus the margin. You can see that in the 5-ALA under blue light, that there's a different hue of red versus pink, depending on the tumor cell density. But we're not at the point yet where we've been able to compare 5-ALA fluorescence versus Raman, though I believe that'll probably be a future direction down the line as we want to be able to compare how sensitive these technologies are, and I'm sure we'll be using them in parallel in future studies.
Thank you.
All right, thank you, Alex, and thank you to all of the oral presenters. Very nice job. Next up, we're going to have virtual poster presentations. So we have 12 presentations. Just a reminder, each of these is 2 minutes to present your single slide. I will give a 30-second time warning towards the end of those 2 minutes. So once the slides come up, our first presenter is Brendan Philbrick, mentored by Dr. Kellner.
Hi, good morning, everyone. My name is Brendan Philbrick. I'm one of the first-year residents. I'm going to be presenting on EVD placement teleproctoring using a camera projector navigation system. This is an early proof of concept study. I think in neurosurgery, many of us are familiar with the different types of intraoperative navigation systems that we use. There's a new type of technology that's coming onto the market, and we were approached by an outside company to help integrate their technology that is camera and projector based. If you look into the bottom left corner image, you can see that there's an example of their setup where they have a projector mounted to an arm and then a 3D depth camera. That camera can then be used to register patient characteristics to a scan and then be able to project in real time different types of clinical information. It could be annotations, it could be patient scans, it could be things used for incision planning. If you look into the image that's just adjacent to it, you can see an example of where an annotation is being projected onto a mannequin in real time. That's 3D that's contoured to the patient and anatomically adjusted. As a proof of concept study, this technology hasn't been used in patients yet, but as a way to validate the usability of this type of technology, we created a study where we wanted to see if projector navigation can be assisted with teaching medical students to identify Coker's point as a proxy for using it in a bedside procedure down the line.
30 seconds.
We enrolled 20 medical students and randomized them to the navigated arm where they would use this novel type of navigation system, and the control arm where they used a paper ruler as well as a textbook to help guide them in identifying Coker's point. None of the medical students were familiar with placing EVDs or or identifying Coker's point. So we had a kind of a virgin population, so to speak. From our data, we found that students that were using the navigated system where a proctor was helping to assist them and using annotations to help identify Coker's point, the students were able to identify Coker's point significantly faster by almost 2 minutes faster than those that were just using a ruler and the textbook definition of Coker's point. Unfortunately, we did not find significance in terms of increased accuracy in identifying Coker's point, although it was trending towards significance where the navigated group, and you can see that in part B of the middle panel, was significantly closer in accuracy to Coker's point. I think that this study was overall underpowered to find a significant difference.
That's time.
General conclusions are that this is a valid technology, and we'll be hoping to bring it to the bedside soon. Thanks.
Thank you. Any questions? Okay, our next speaker is Jeffrey Zimmering, also mentored by Dr. Kellner.
Thank you. Prior studies suggest WhatsApp messaging allows fast and cost-effective clinical communication, facilitating patient management. We evaluated how Mount Sinai Health System end users in the ICH WhatsApp group perceive its effectiveness and shortcomings. We developed a survey comprised of 52 questions and using a 5-point Likert rating scale. A database was also created of all WhatsApp communications that took place between 2016 and 2021. The database provides information about the efficacy of WhatsApp in shortening the time from initial contact to patient disposition and whether the consult encounter process results in open or closed loop communication. Here are the data from the first 32 respondents. 50% were in neurosurgery with 25% in neurology or neurocritical care. The average daily and weekly time spent on WhatsApp was 3.1 and 16.6 hours respectively. Most respondents belong to more than 10 different WhatsApp groups. About a third were residents with 22% each attendings or APPs. Sharing patient updates and consults for transfer were identified by 90% as the most important functions of WhatsApp. Close to half thought that response time to WhatsApp was adequate. 62% felt the need to review the chart for missing information. A third reported that the sender had inadequate knowledge about the patient. About a half of respondents felt that the use of WhatsApp could lead to misunderstandings about patient status and patient care. Close to 60% felt that WhatsApp results in lower work productivity and performance, and more than 70% reported that it reduces their personal well-being. Nearly half viewed WhatsApp as contributing significantly to burnout. Only a quarter felt that it contributed significantly to teaching or educational opportunities. Slightly more respondents, 34% versus 28%, viewed WhatsApp as streamlining versus complicating information flow. Yet 70% felt that the use of WhatsApp for clinical triage saves time. In summary, despite its widespread use, WhatsApp was perceived as distracting from other tasks, reducing work productivity, and contributing to burnout. Our goal is to use the information from the survey to design a consult transfer template that will facilitate closed loop communication and improve user satisfaction. Thank you.
Jeff, to expound on your future direction, what do you think would make a sort of less fatiguing, burning out type platform that would still be useful in this busy environment?
Yeah, that's a very difficult question to answer. I think one of the biggest problems that we want to address is alarm fatigue within WhatsApp. I think we have to reduce the amount of groups, the number of groups that people belong to. I think that's the number one thing that we need to do. In our preliminary analysis of the outcome measures that we looked at, particularly closed versus open loop communication, we found that 70% of the time, a WhatsApp encounter process did not result in closed loop communication. So even though we have this technology, instead of kind of just throwing it out there and running wild, I think we need to, now that we have data, find ways to more smartly use it so that people feel satisfied.
It's a great point. I think to your point of alarm fatigue, there's a lot of really good literature on this in the various medical device areas like insulin pumps and sort of other medical devices that have alarms and alerts for users. So you could look into that as well for sort of how to design a system.
Thank you.
So next up is Matthew Carr, mentored by Dr. Margettis.
Thank you so much. So as Dr. Morgenstern said, my name is Matt. I'm one of the PGY2s here. I'll be presenting on some clinical research I've been doing with Dr. Margettis and Dr. Kim from the Department of Orthopedics, looking at lordosis correction intraoperatively during cervical spine surgery. So one of the main goals of any cervical spine fusion is to either maintain or create a normal cervical lordosis and alignment. And there's many different methods that have been tried to do this. Two which are commonly used here are bivector traction, which you can see in the figure in the middle here. The patient is in Gardner-Wells traction with a horizontal extension traction, but then also this sort of superior projecting traction, which is the bivector traction, providing traction in two vectors, versus just simple head elevation, which often is obtained by placing a sheet or towels under the purple foam face mask here. However, there's no real direct comparison between these two. So our objective was to try to directly compare bivector traction versus head elevation in lordosis correction intraoperatively. We looked at our sample of patients who have undergone C2 to T2 posterior fusion with both bivector traction and head elevation methods used with intraoperative fluoro images using both methods. We measured cervical lordosis intraoperatively with a Cobb angle between the C2 inferior end plate. And as you're all aware, it's very difficult to visualize, below C6 often with the shoulders on fluoro. So to measure the T1, approximately the T1 superior end plate, we placed a pedicle tap instrument in our pedicle hole to approximate the T1 superior end plate. And we then used a Cobb angle to measure cervical lordosis. We've had 13 patients so far with both methods, and we found that head elevation produced a greater cervical lordosis, 16 degrees versus 13.3 degrees. However, this finding did not quite reach significance due to the low power. We also measured using both together, and that was statistically better than using bivector traction alone, and no different than using head elevation alone. So our findings suggest the head elevation is superior, but maybe not significantly so, to bivector traction in intraoperative cervical lordosis creation. Thank you.
Do we have any questions for Matt? Okay, so on to our next poster. We have Dr. Yeager, mentored by himself.
Thank you. My name is Kurt Yeager. I am Chief Neurosurgical Resident here at Mount Sinai, presenting my poster on U.S. regulatory approval of medical devices used for endovascular treatment of acute stroke over the last 20 years. So endovascular devices for stroke have been developed since the early 2000s. And there's been a lot of, in the most recent years, a lot of changes to development in the regulatory pathway. And so we wanted to look at specifically how the landscape of endovascular devices have been regulated by the FDA in those 20 years and how it's changed over time. And we also wanted to look at how specifically they changed after the major positive randomized control trials were released in 2015 and 2018. So we looked at open databases by the FDA, looking at the different pathways of regulatory approval, the 510(k) pathway, which is for intermediate risk devices, PMA, which is for high risk devices, HD, humanitarian device equivalents, and then de novo for other medium risk devices. We looked at various device categories, whether they were stent retrievers, aspiration catheters, micro wires, etc. We looked at the various companies involved that were seeking approval for their medical devices, and we looked at time between submission and approval for all these devices. So in this 20-year period, we found 136 endovascular devices that were used for stroke, that were approved during this time frame. A vast majority, 95%, were approved via the 510(k) pathway, and the remaining devices were split between the humanitarian device and the PMA pathways. Those were the latter ones were all stents, intracranial stents. 84% of these devices were approved after 2015, and that was our cutoff because most of the randomized trials were published at that time.
30 seconds.
And 51% of those devices were first in a generation, compared to subsequent generations that the approval is based off that first device. And overall, the approval time averaged 117 days. Interestingly, comparing endovascular devices for stroke relative to all neurological devices approved, between 2000 and 2015, between 0 and 6% each year were endovascular devices, whereas in the past 5 years, the device for endovascular use in stroke have increased significantly, and last year is up to 20% of all devices were used for stroke. So overall, the take homes are that the number overall and the proportion of stroke devices have been increasing from between 2000 and 2021. Most specifically, if you can see figure 1, rapidly in the past 5 or so years. The number of companies have been increasing, seeking approval for medical devices used in stroke. 80% of companies had their first device approved for use after 2015, and those were mostly startup companies with only 1 or 2 devices. Earlier on, stent retrievers were a majority of the devices sought for approval, but then most recently, aspiration and guide catheters tended to be most common. And as I mentioned before, the only non-510K approved devices were intracranial stents, which represented a higher risk proportion of devices. Interestingly, of note, in the figure in the top right, you can see that the difference between the first generation and subsequent generation devices, the subsequent generation devices had a shorter time to device approval from submission, which makes sense given that they're based on the initial predicate device. Thank you.
Thank you, Kurt. Do we have any questions? Okay, our next poster is presented by Frank Yuck, who is mentored by Dr. Caridi.
Good morning. Frank, I'm one of the PGY6 residents. So we compared the two approaches, anterior versus posterior approaches for the treatment of thoracic myelopathy. Thoracic myelopathy, most commonly is associated or caused by ossification of the ligamentum flavum, a posterior bone spur, intervertebral disc herniation, or OPLL, and degenerative spondy. So we queried the NSQIP data for all patients that underwent anterior transthoracic versus posterior decompression for degenerative thoracic myelopathy from between 2007 and 2015. And we found 85 patients underwent anterior versus 47 that underwent posterior. And the average age and other demographics were well matched. The average length of stay was approximately the same, 6.8 days for anterior versus 7.5 days for posterior. However, there was a longer operative time for posterior versus anterior, 221 minutes versus 171 minutes. This is usually due to the fact that posteriorly, you're usually fusing to go transpedicular for decompression of intervertebral disc versus anterior transthoracic. Once you're down onto the disc space, usually not fusing, you're usually just doing a small discectomy and removing the disc. And however, serious adverse events were greater in the posterior versus the anterior approach, about 30% versus 18%. And this is mostly reflected in the return to OR for posterior, which is 10% of the time, increased ventilator day for over 48 hours, and increased rates of sepsis, but no statistical difference in the neurologic outcome. However, for most practices, including ours here at Mount Sinai, we tend to favor posterior lateral decompressions or fusions, and it really depends on the surgeon's comfort level to dictate the approach, whether it's anterior thoracic or posterior lateral. And many surgeons avoid anterior transthoracic because of the increased risk of pulmonary complications having to go deflate the lungs. I'm done.
Do we have any questions for Dr. Yip?
All right. Sorry.
Go ahead,
Frank. How did you assess neurological outcome? Great presentation, by the way.
So we assessed the neurological outcome for any decrease in neurologic function, whether they lost motors intraoperatively or postoperatively, whether they had a decrease in motor function, and that was all corroborated with anterior versus posterior.
Did you use any standard day scales?
No, I think it was just whether or not they had any decrease in neurologic function.
I see. Thank you.
Okay, next up we have Denzel Faulkner, who is presenting a project mentored by Dr. Rappaport.
Good morning, everyone. I'm a PhD student that's working at biodesign with Dr. Rappaport, and we're currently looking at meningiomas and specifically tumor embolization. So as we all know, endovascular embolization is an adjunct for surgical treatment, and it has a lot of benefits, especially during the resection where it's believed to reduce blood loss, and also it has a lot of texture changes that it can impose on the tumor for when they're taking the tumor out. And one thing that has come to our attention, especially after doing the literature search, is that a lot of these cases where people have meningiomas, MRIs are done before any embolization takes place, and then MRIs are taken after surgical resection. So in these cases where we do tumor embolization, we don't exactly know what's going on after the embolization, protocol itself, and how that's affecting tumor physiology or morphology. And so we present here a study where we look at addressing exactly just this. And so thankfully in 2021-ish, we established a protocol within the hospital where there's an additional MRI imaging sequence that takes place in between the surgical resection. So there's an MRI before anything happens, an MRI after tumor embolization, and a last MRI after resection. And we're able to here look at 26 consecutive meningioma cases in which we looked at T1 weighted images, and we did an image analysis and a segmentation where we're able to make our own metric for extent of embolization ranging from 0 to 1, 1 being complete tumor embolization and 0 being none really detectable. Of the 26 patients, we found that 9 of them showed low embolization extent, so below 0.25. 10 of them showed medium, between 0.25 and 0.75. 7 of them showed high embolization extent, which is greater than 0.75. And in the figure in the middle on the bottom here, you can see an example where before embolization, everything is brown. So, nothing has been embolized in the MRI. None of the contrast that is being supplied has been attenuated yet. And post-embolization here for this particular patient, we see the green is where it's embolized, and that's where there's no contrast being shown in the image. Whereas the brown in that post-embolization in the right column is the residual contrast that's still there. So it's the non-embolized portion. In this example, this person had an extent of embolization of 0.82. And so this is kind of like a pilot study that we're working on right now. And I aim to not only continue refining this process of analysis, but I also aim to do this with way more patients in the future, because it's really hard to come to any significantly statistically significant conclusions with just 26 patients. But this is really a critical first step at understanding exactly just what's going on with these tumor embolizations with these patients before surgical resection, and if maybe you could find a way to improve it. Thank you for your time.
Thank you, Denzel. Do we have any questions for Denzel? Very nice project. Thank you. We'll move on to Ray Fang, who is mentored by Dr. Kilner.
Okay. Can everyone hear me?
Yes, we can.
Okay, thank you, Dr. Morgenstern. And thank you for giving me the time to present. My name is Ray Fang. I'm one of the PGY4 resident. So today I will be talking about utilizing computer vision technology to automate surgical video analysis. So for the surgeons in the room, everybody probably had the experience that reviewing your own intraoperative videos can be really helpful. And systemic studies has also shown that it can improve patient outcomes as well as shorten surgical time. However, doing that has a lot of limitations. For example, it takes extensive time and labor just to transfer and organize the data, catalog, locate, and edit critical sections, as well as performing systemic analyses. So in our study, we're aiming to develop a software platform that leverages patented computer vision technology, and we aim to streamline that whole process, and also conduct automated analyses that includes tool tracking, surgical screen classification, etc. And our goal, our hypothesis is that with the development of this streamlined process, it can save surgeons time and gain wider utilization for surgical video analysis. So I'm showing some of the preliminary results. Our surgical scene classification algorithm can achieve a very high accuracy, as well as our surgical tool tracking. And the video is not really playing, but it's an example of our surgical tool tracking, which can identify the correct surgical tool in the scene and track its motion. And also other tools and functions can include the camera motion estimation and smoke detection that can optimize and enhancing the surgical view. So in conclusion, and for future directions, we think it is feasible to automate the surgical video analysis, and also the automation of this process gives data that has a lot of potential use in things such as enhancing surgical skill education, performance tracking, as well as individualized technical development. Thank you.
Hey, Ray, thanks a lot. Great presentation. Can you apply the same technology to different types of videos, or is the work you did here specific to endoscopic videos?
So currently, most of our analysis is done on endoscopic, but we're definitely working on expanding that to be more adaptable to all different kinds of surgeries.
Cool.
This would be a great thing to apply to the microscope and potentially even like endovascular approaches. I'm sure that's what you're thinking, Chris.
Yeah.
Exactly.
Great. All right, we'll go to our next presenter. We have Jeff Gilligan, mentored by Dr. Marquez.
Good morning, Jeff, one of the chief residents. The study was basically focused on investigating the utility of providing neurosurgical emergency education to other specialties. To do this, I gave lectures to 96 internal medicine and emergency medicine residents over the Mount Sinai system, focusing on neurosurgical emergencies, common like subdurals, subarachnoids, and cauda focusing on their presentation, initial treatments. And then to kind of study this, I gave a pre-survey and then a post-survey, and used a 5-point Likert scale to quantify this. I had good response, 100% response rate, and a good response in terms of them thinking that it was a benefit for this lecture, where 0.5 point improved for just overall comfort of treating patients with neurosurgical emergencies, and about a 1 point increase for comfort identifying emergencies and initiating treatment. And then also believing that it would be beneficial to have further education on such emergencies. The other 4 questions kind of just focused on just overall whether they benefited for this, whether it was appropriate for their specialty and level, and as well as if they would recommend this to other colleagues, which majority of them either agreed regular or agreed strongly. So this just showed that a single lecture can improve these other residents and other subspecialties for identifying neurosurgical emergencies and initiating their treatment, and further lectures or other forms of education could significantly help improve other non-neurosurgeons or physicians or APPs in their neurosurgical education. Thank you.
Jeff, this is a really nice study that shows just how valuable it can be to have specialists giving general education to non-specialists. I think you could probably generalize this for every single specialty field. Mm-hmm. But do you envision, can you think of a way to potentially implement this without making us appear as though we are sort of putting ourselves on an educating pedestal and saying we have to teach you, like incorporating it into generalists curricula or things like that?
I mean, I think a lot of people just do this on their own. I'm sure you give some pediatric lectures and people else to just kind of develop relationships on a resident level. It's hard to kind of find that time, but I think for me, I find it beneficial just because it develops those relationships and you kind of get a better rapport with these other subspecialties. But I guess we could talk offline about kind of going forward.
Yeah, I mean, I think connecting with residencies like the pediatrics and IM and EM and sort of offering to be part of their annual curriculums could be really, it can pay dividends both to the recipients of that education and also to us and to our patients.
Thank you.
All right, next up we have Alejandro Carrasquilla, who is presenting a project that we worked on together.
Good morning, and thank you. My name is Alejandro Carrasquilla. I'm a PGY5 resident. We carried out a systematic review and meta-analysis of modern literature comparing outcomes of endoscopic transnasal approach versus open craniotomy or transcranial approach for resection of pediatric craniopharyngiomas. The pediatric neurosurgery literature lacked this type of comparative meta-analysis on this topic, and we hypothesized that endoscopic transfemoral surgery had comparable safety to craniotomy for pediatric craniopharyngioma resection. We queried literature and identified a final 65 eligible studies with 792 patients. Data was extracted from each study, tabulated, and analyzed using chi-square and Fisher-exact tests. The middle panel demonstrates our results. On the top of the chart, you see one column for endoscopic transfemoral approach in yellow and transcranial approach in blue. Tabulated below is the result for each measured outcome, color-coded so that green depicts a benefit for an approach within each outcome. In other words, the endoscopic transfemoral approach had greater CSF leaks, lower rate of diabetes insipidus, but higher rate of other endocrinopathies. Endoscopic transfemoral approach had greater rate of meningitis, lower rate of seizures or pseudoaneurysms, but superior visual outcomes compared to transcranial approach. There were no significant differences in mortality, gross total resection, obesity, stroke, or hemorrhage within the two approaches. Additionally, we compared our data in pediatrics to a similar meta-analysis carried out in adults by Komodar et al. In 2011, which is depicted in the right-hand panel. This chart denotes the approach which had superior outcome within each category in the corresponding study. So our study showed no significant difference in gross total resection between approaches, while the adult meta-analysis showed higher rate of gross total resection with endoscopic transfemoral surgery. There were similar findings between studies for visual outcome, CSF leak, seizure. Of note, our study demonstrated higher incidence of diabetes insipidus with the transcranial approach in pediatric craniopharyngioma patients, while the adult study demonstrated higher incidence of diabetes insipidus in endoscopic transfemoral surgery. Both studies showed higher incidence of hypopituitarism or other endocrinopathies in endoscopic transfemoral approaches. Our study demonstrated a higher incidence of meningitis with endoscopic transfemoral surgery as well. There were important limitations, including inherent selection bias within many case series favoring craniotomy for larger tumors with lateral extent. Additionally, for the comparison with adult patients, the adult meta-analysis occurred 10 years earlier, during which the approach and technology have evolved. Furthermore, there are special surgical considerations in pediatric patients where the role of adjunct radiation may be limited due to possible neurocognitive effects, necrosis, and secondary malignancy. So altogether, this meta-analysis supports the feasibility of both approaches for craniopharyngioma resection in pediatric patients and further details the benefits and drawbacks of each so that treatments may be more precisely tailored to specific cases. Thank you. And thank you to Dr. Morgenstern and all who were involved. Thanks for letting me present.
Thanks, Alejandro. Any questions? Okay, so next we have Abi Bhimani, who's presenting a project mentored by Dr. Margettis.
Hi, good morning, everybody. My name is Abi. I'm PGY3 resident at Sinai, and I'm going to be presenting about ultra early surgery for thoracic spinal cord injuries, a systematic review and meta-analysis that I did with Dr. Margettis and the rest of the team. Mentioned about. So a little bit of background that there have been previous studies. There have been previous studies in neurosurgical literature as well as orthopedic literature regarding timing of decompression for spinal cord injury, especially the timing of less than 24 hours, which has deemed to be effective. However, there haven't been a large study or even as many studies that are looking into a much narrower time frame, which includes an ultra early decompression, which would be less than 8 hours from the initial insult. So our study did a meta-analysis of the current literature, as well as included our own institutional data from patients to compare the Asia outcomes between the patients receiving decompression less than 8 hours after thoracic spinal cord injury versus patients receiving decompression greater than 8 hours. We did a standard electronic database search following PRISMA guidelines and exclusion criteria that included studies that studies with ultra early decompression and excluded studies that do not have a group that has less than 8 hours of decompression. We limited our studies to prospective studies as well as randomized control studies. And we did we ended up studying five total studies, including our own institutional study, which had 75 total patients included. 54% of them were in the ultra early group and 45% were in the comparison group. We did a quantitative analysis as well as an arm-based meta-analysis, depending on what criteria the studies fit. We use a standard mean difference model for quantitative analysis, which showed a significant improvement in the ASIA score in patients receiving decompression less than 8 hours, with an effect size of 1.46 and a significant p-value of less than 0.001. On the other hand, on the arm-based meta-analysis, which included more patients, all 75 of the patients, we not only found that there was a significant treatment effect for the group 1, which was the ultra early, but that there was no significant improvement on group 2, which was patients receiving decompression greater than 8 hours. And the comparative analysis also shows that the effect difference was significant in between the two studies. So the two plots, the top plot, as you can see, is a contrast, is a treatment effect density plot where you can see the treatment 1 being the less than 8 hours decompression, showing significant treatment effect compared to treatment 2, which is greater than 8 hours of decompression.
Time, Abby.
And yep. So we overall, we found significant improvement in mean ASIA scores on patient undergoing decompression less than 8 hours. And this is the first study.
Do we have any questions? All right, thank you. We'll move on to our next speaker. We have Max Bazile, who is mentored by the Vein of Galen group, Dr. Fifi, Dr. Bernstein, and Dr. Shigematsu.
Thank you, Dr. Morgenstern. Hi, I'm Max. I'm an incoming MS1. Vein of Galen malformation is pretty rare, although in our practice it's far more prevalent. It's not quite a malformation of the vein of Galen, but rather of the persistent pediatric prosencephalic vein of Markowski, which is the precursor to the vein of Galen. In some of these vein of Galen patients, children, neonates, we've seen either within the treatment course or prior to it at presentation, an upregulation of this fine vascular network, something that in some publications has been called angiogenesis, in other places has been called dural recruitment, or just a general collateral network. What we've noticed, or what we believe is a unique phenomenon, is this dynamic progression of feeders that appear in the subependymal zone and the subarachnoid space, which is a reversible phenomenon and differs from dural recruitment in the sense that it's a hair-like plexiform network. The key points to take away are that patients who present with this network at first presentation, meaning at the very first radiographic scan, tend to be older, which suggests to us that patients need to be referred quickly and treated expeditiously in order to avoid this phenomenon. But why is this phenomenon a problem in the first place? Well, what we found is that not only do vein of Galen malformations who present with this phenomenon or have this phenomenon during their treatment course require more treatments, but in fact, it also complicates the treatment timeline and identification of the pathology. For example, the misrepresentation of a vein of Galen malformation as a tectal or thalamic AVM. Again, subarachnoid space FVNF or SEZ FVNF doesn't cause any symptoms in the patients, but it does cause complications to the surgical timeline in the sense that as we begin to embolize arterial feeders to the malformation, the smaller hair-like vessels remain. They diminuate over time, and yet they remain, which is why transvenous embolization, which we found to be a highly effective treatment modality, becomes a problem now, because we increase the risk of hemorrhage or stroke substantially with these fine arterial feeders that are unable to be catheterized. So we've noticed three main patterns of that FVNF expansion or regression, either a progressive decrease in FVNF after the initial presentation, an original upregulation and then diminution, or cycling of increases and decreases in FVNF, which a number of publications in the literature currently believe it to be due in the case of post-embolization FVNF to inflammation, to hemodynamic impedance, to hypoxia, which is why, based on these findings, we've developed a new study to approach this from a multi-omic standpoint and determine what exactly causes this network to form, which we've begun enrolling patients in, and we'll have them sample intralesional and peripheral blood, both for proangiogenic patients, like the ones you see in this cohort, and those that eventually achieve complete cure. There are many future indications here. This is a list of 36 patients who had a complete treatment course at Mount Sinai, but there are a number of patients who have much more aggressive FVNF whose treatment courses are even complicated as we speak. And therefore, we believe that this multi-omic study will shed some light, but more importantly, the main takeaway is treat expeditiously, refer quickly, and make sure to nip this in the bud as you see it, because it can be reversed and it does diminuate over time with staged transarterial embolization. But of course, it does prevent transvenous embolization from being as effective. Thank you.
Hey, Max, that's really interesting. I feel like we see this in standard arteriovenous malformations also. Did you find that the treatment timing or treatment attempt technique either led to the formation of more of these networks or led to a higher chance of them diminishing over time?
We found that patients who seek treatment later, or at least have, or at least we can say that the group of patients who present with this network are older, and they're typically ones who have not been treated before. There was a lot of literature in the AVM world, as opposed to vein of Galen malformation world, to suggest that incomplete closure of the arterial pedicles will cause more aggressive FVNF style networks or dural recruitment to occur. So yes, treating incompletely and leaving the AVM, or in our case, the VOGM, without treatment for an extended period of time can cause this network to increase or become more aggressive.
Yep. Stavros?
Thank you, Max. I have two questions. First of all, how much older are these patients that they present with? You know, if they're not treated in a timely fashion, they present, you said they're older, they present there with this network. How much older are they? What's the range of their age? And secondly, do you believe that this multi-omic study will provide some insight of how we can select patients who, like, what portion of the patients will have less degree of postoperative hemorrhage if we do transvenous approach?
To your first point, the standard deviation of the older cohort is quite large, but it favors upward. So while the average is about 12 months, there are patients who do not identify that they have a vein of Galen malformation until they're 6 or 7 years old, for example, before they present to our practice. And in those cases, FVNF networks were quite common. And then it was about 4 months with a standard deviation of 5 months for the younger group, which was significant. To your point about the multi-omic study, the multi-omic study exists as a supplement to a number of extant studies for vein of Galen malformation in the genomics world, and then for AVM overall. There is no specific gene or protein that has been linked to vein of Galen specifically, only the, for example, hemorrhagic hereditary telangiectasia genes that we see in the AVM literature. But as far as predicting hemorrhage, it does stand to reason that if you do not identify this network early and you attempt transvenous embolization, that you may be causing an increased risk of hemorrhage without realizing it. So by selecting patients who are less likely to develop this network and treating them expeditiously, or by identifying the ones who are more likely to produce this network and being far more careful or conservative with your use of TVE may be an effective strategy. For anyone who is interested in the images of the diminution, I apologize that it's so small on the screen, but you can see that with progressive TAE in the bottom images, in one case that began without FENF in one case that presented with it at the beginning. It does decrease over time, which would increase the safety of a TVE procedure, but there are cases where this cycles back up. And it would be important to identify which proteins, which RNAs, what genetic markers may lead to that cycling pattern or just the formation of it at all.
Great, thank you.
Nicely done, Max. We'll move on to the next poster. We have Danielle Chalutz. This is our final poster presenting a project mentored by Dr. Margettis.
Hello, everyone. My name is Danielle. I'm a second-year med student. I'll be presenting a case series on myxopapillary ependymomas. Just a little background. Myxopapillary ependymomas are a very rare and complex tumor. They have a predilection for the lumbosacral region, and they're associated with low resection and high recurrence rates. Their natural disease course is not well understood. It's also highly variable and unpredictable. It was previously thought to be a grade 1 benign tumor, but it has now been redefined as a grade 2 tumor due to its tendency to infiltrate and recur. So we looked at 19 patients that were operated on between 2010 and 2021 in Mount Sinai. And just a little bit about what we found. The most common presenting symptoms included back pain and lower extremity pain, in addition to numbness, spasms, weakness, bladder and bowel dysfunction. All the tumors involved the lumbar region and 4 extended into the thoracic region. Gross total resection was only achieved in 13 out of 19 cases, and 13 patients experienced postoperative neurological deficit. 2 received adjuvant radiation in addition to the surgery, and 1 experienced recurrence. If you look at the table, this just kind of outlines the outcomes, the overall outcomes. You could see that a lot of patients, regardless of gross total resection or partial resection, experienced neurological deficit following resection. And if you look down at the bottom, the back pain outcome and the leg pain outcome, which are the most common presenting symptoms. You could see that a lot of the deficits continued even after resection. And there are some patients that even experienced some new neurological deficits, which is interesting to see. So I guess we could conclude that gross total resection is really only feasible in 2/3 out of the cases. And postoperative neurological deficit, regardless of gross total resection or subtotal resection, is very significant. There's a high risk for it. And it'll be interesting to see how treatment evolves, if we could get a bigger sample size to further understand what really plays a role in the recurrence and if radiation has a significant impact. Thank you.
Thank you very much, Danielle. Does anyone have any questions? All right, thank you again to all the presenters. Really nice job. I think this is a great showcase of some of the excellent work that everyone is doing here. And now we'll move on to the awards. So I'll turn it back over to Dr. Hadjimanayas.
Yeah, great job, everybody. And thank you, Peter, for running that very efficiently. I think we were just 1 minute behind schedule, which is remarkable. So we're going to move on to the awards part of the research day today. And the first award we're going to discuss is our Neurosurgery Resident Publication Award, which is the Cal Post Award. Next slide. So Dr. Post is our former chair, and he established this award in 2007. And it really acknowledges scholarship by a resident, and it's really the best peer-reviewed manuscript published or accepted for publication. So this is something that the professors in the department decide on. And, I don't think Dr. Post is with us today, but he's usually quite active with our educational conferences. So we're really happy that he's still part of what we do here. So the winner, well, we're not quite ready for the winner yet. So the articles, go back one, go back to the articles. I'd just like to highlight everybody who submitted one. So Kurt Yeager, our chief resident, submitted this paper that was published last year in JNS. Next slide. And Ray Fang provided this paper that's in Press in Neurosurgery. Alex Schuper submitted a paper in Frontiers in Neurology. this past year. So the winner is Ray Fang. So Ray's paper on pragmatic prediction of excessive length of stay following cervical spine surgery with machine learning and validation on a national scale was the highest scoring publication and received the Cal Poster Award. So congratulations, Ray. Strong work.
Thank you, Dr.
Love that smile, by the way. Keep smiling. Okay. So now we're going to go into who won the award for best oral presentation and then runner-up. We'll start out with the runner-up. Dr. Chang was kind enough to listen to all the oral presentations, and then he provided his 2 top scoring presentations. So let's start out with the runner-up, which is second place, which goes to Trevor Hartigan. So Trevor, congratulations on your presentation.
Great, thank you so much.
Okay, great. And then now let's go to our first place award, which is Jonathan Dulio, whose presentation was on atypical meningiomas, and his research mentor is Raj Srivastava. So congratulations, Jonathan, on an awesome presentation.
Thank you very much. Appreciate it.
Okay. Well, I think that wraps up our research day presentations. I think everyone did a great job, and the residents get to spend time with Dr. Chang now, and they have lunch that they'll go to now. So I think if we don't have any other questions or any other remarks, I think we're going to close it out here. Thank you, everybody, for a pretty jam-packed morning. I thought it went well, though.
Thank you again, Eddie. Unfortunately for you, it's a virtual lunch, not a real one.
No problem. Virtual breakfast.
Exactly.
All right. See you guys all soon. Great to see you.
Thank you, Eddie.